Go ahead and get started. We have two committee members who will be joining us shortly. My name is Holly Mitchell. I'm chair of Sub 1, representing the 47th Assembly District. Let me just briefly say, as I've announced at the hearings last week when we got started, that we are on a very short, to say the least, time frame with regard to the subcommittee process. This is hearing 4 of a scheduled 7. Our goal is to recognize that we are making critical decisions over the next several weeks that will impact the health and safety of Californians, and we take that charge very seriously. We have fundamentally 3 goals for each of these hearings. First, it's my goal as chair to run an efficient hearing that kind of respects the time of my fellow committee members and all of you as witnesses, many of whom I know have traveled to be with us here today. In order to do that, please know that based on the agenda item, if there are significant numbers of people who want to provide public testimony, I hope that you will understand that I will give you a time limit and ask that you honor the time limit to respect your fellow witnesses. To do that, I think it's really critical that you not repeat points that a previous witness has stated, and that you make your own testimony, be it 30 seconds, 1 minute, or 2 minutes, as impactful and provocative and salient as possible. Again, we really thank you for coming out to participate in this process. This is the best way for members of the legislature to receive information and fundamentally understand the back end of the decisions we're being asked to make through this budget process. With that, I'll ask for roll call to establish a quorum, and we'll get started today with today's hearing.
Mitchell.
Here.
Chesbrough.
Here.
Jeffries. Mansour. Mawning.
Here.
Thank you. We'll get started with Section 4280. Mr. Mibb, the Managed Risk Medical Insurance Board. If the Department, Finance, and LAO will all come to the table. I'm sorry, would the sergeants mind taking the podium off the table? Because the person who sits in that third seat has to do acrobatics to try to make eye contact with the chair. So if you would remove that, I think that would be easier for everybody. I appreciate that. And we'll ask the department, Mr. Mibb, staff, to begin with the overview and move directly into issue 1, which is the proposed elimination of vision coverage under the Healthy Family Program. Thank you.
Good afternoon, Madam Chair. My name is Jeanette Casillas. I'm the Executive Director of the Managed Risk Medical Insurance Board, also known as Mr. Mibb. I will be brief in my comments. I will not read to you what's already been presented, and respectful of the time constraints, and here to answer any questions that you have. But overall, most of the changes that are before you for budget proposals impact our Healthy Families Program, which is our program for uninsured children 0 through 19. We have comprehensive benefits, health, dental, and vision at the moment, just as the legislature and state employees have. We have a cost sharing in this program of premiums and copays, which I will talk about on the different budget proposals before you. So the very first proposal before you is the, let's see here, the elimination of vision coverage for our children. The budget proposes that we would eliminate vision as health and dental coverage are mandated benefits under the Reauthorization Act. Every one of our children, we pay a capitation for every single child that's in our program. And we will note that there are some staff comments and questions relative to this proposal as it was already presented back in the May revision. It is the case that we continue to work with one of our largest vision plan contractors to look at other options should this committee choose to consider those as opposed to elimination of the benefits completely.
And do you have a projected timeline as to when that proposal will be ready for review?
I would defer that to public comment because VSP will be present to make public comment on that. We are working closely with them, but we're waiting to see what type of fiscal they can present to us for review and comment.
Great.
Moving on, we also have another budget proposal to increase Healthy Families premiums in the program. We have what we call...
Excuse me, we're just going to take one issue at a time.
Oh, I'm sorry.
So we'll just... So are you done with the vision elimination?
Yes.
Finance.
Okay. Tom Williams from the Department of Finance. We would just note that given the state's current fiscal crisis and the limitations on under healthcare reform on the maintenance of effort requirements, the elimination of this optional vision benefit is one of the few options left to the state to try and reduce program cost. And there are a couple of states currently, I believe Utah and Nevada, that don't offer a separate vision plan in addition to the vision services that they get within their health plan.
And Utah and Nevada are the only two?
That's correct.
LAO.
Good afternoon, Madam Chair, members. Meredith Worden with the Legislative Analyst's Office. I'd like to start with a couple of global comments about these proposals that you're going to hear today, both in the Healthy Families Program and the Medi-Cal program generally, in that many of these proposals were proposed as part of the prior administration and heard at the May revision and already rejected. Given the state's deteriorating fiscal situation, we recommend that you reconsider these proposals. We recognize that these are very difficult proposals that will have very real impacts on the program beneficiaries. And because the legislature has rejected these proposals prior, we also provide some alternatives for the legislature to consider. Our alternatives would generally have less impact on beneficiaries, achieve less in savings than the governor's proposals, and may in some cases be more burdensome for the departments to implement. And with regard to the vision benefit, we do recommend that you approve the governor's proposal to eliminate the benefit. We are making this recommendation on a fiscal basis, not a policy basis. However, we also understand that one of the plans, VSP, that provides the vision benefit is working on a lower cost alternative. We recommend that you do consider this alternative, although it's likely to achieve less in savings than eliminating the benefit.
Great. Any other comments before we move to public comment?
No.
So could, Mr. Chesborough.
I heard a sort of a general reference to this in the LAO's comment, but the other alternatives that are cited as possibilities in the agenda document, have there been any cost analysis to try to compare what the relative savings would be in exploring any of those other alternatives?
We don't have any additional cost analysis of those alternatives identified in the agenda.
And what about the department?
We are working with VSP. Now, VSP is only one of 3 of our contracted vision plans, although they do have about 80% of our enrollment. So we are looking to refine those estimates now with them.
What about comparing what Medi-Cal does and what kind of cost of savings might be achieved by pursuing that as an alternative?
I would say that is something that we are exploring. However, I would tell you that since we know it's all new to us, the likelihood of actually going down that particular path in the budget year would be very challenging. We would be working on a new process that we're not familiar with, new contractors. We've never worked with Prison Industries Authority. Not that we couldn't. It would challenge us to have a 12-month savings in the budget year.
But when this cut was proposed previously, those alternatives were not apparently explored then as
the PIA was a new idea that came up this year, or
what about
during
the
this
vision
proposal.
Services? What about the health plans?
The health plans, we had done a survey and it was not completely baked. We did an internal survey with them, and the rates were all across the board, and it was not well-defined as to what services that they would offer, so it's undetermined at this time whether we would be achieving savings. One would think so, but we would have to go back and actually, we're actually in the process right now of getting ready to begin our rate negotiations.
Thank you. Thank you, Madam Chair.
Are you the representative from VSP? If you could come join us at the table. And so if you could include in your testimony the time frame and some of the issues Mr. Chesbrough raised, that would be helpful.
Am I on? Okay. My name is Lucinda Ward. I'm a regional manager with VSP. I've worked with Mr. Mibb and Healthy Families since the inception of the program. As Jeanette stated, we cover about 80% of the kids, 700,000 kids in all counties throughout the state under the program. We understand the fiscal situation and the importance of it, and we are working diligently to come up with some alternatives. VSP is a not-for-profit organization. We do provide eye care through our Sight for Students program to children. Children are very important to us, so this is near and dear to our heart. I just would like to state a couple things. 80% of what children learn is through their eyes. 1 in 4 children have some form of vision correction, and it's very difficult for children to learn without being able to have materials. Some of the alternatives we're looking at are in the beginning stages. Some of the cost savings we have looked at are between a third to potentially, in the worst case scenario, 60%. So we're looking at a variety of alternatives, and at our home office and here in Rancho Cordova, we're looking at absolutely everything to figure out how to save this program. The time frame is, we've been having conversations late at night, all of the time, to be able to come up with alternatives. So as quickly as possible, we should be able to come back with some price savings, I would imagine, by middle of next week at the latest.
Oh, great.
And so be able to have an alternative. We would just strongly consider that you put this on the table until you have some other alternatives to look at. Thank you. Any other questions?
Why don't you stay there in case we do?
Okay.
Any other questions of the committee? We'll open up to public comment.
Madam Chair and members, Monica Miller on behalf of the California Optometric Association, and we're opposed to this elimination. As VSP said, 25% of all school-age children have vision problems. It does lead to learning disabilities, et cetera. So if we catch it early, we're able to get those kids, as LBJ would say, to the starting line, and we think that that's really important. So we urge that you do not consider this and at least work with VSP. So thank you.
Thank you.
Nisette Short with the 100% campaign in Pico, California. And we have a coalition that's working towards ensuring that all California's children receive health care coverage. We're opposed to these cuts for the reasons already stated about the global impacts on children in their lifetime of learning, their early development. We know you have tough cuts to make, but it's really important for you all to consider the one cut and how it impacts children kind of in so many different facets of their lives. So we oppose these cuts, and we urge you to as well. Thank you.
Thank you very much. Next witness.
Madam Chair and members, Vanessa Kahina with the Western Center on Law and Poverty, here in opposition to the elimination of Healthy Families vision coverage for the reasons stated before, but also if we're really talking about building a workforce that California can invest in later on, this is one of those things that we should be doing so kids can read the board.
Thank you. Next witness.
Chair Mitchell and members, Jeff Tom, immediate past president, California Council of the Blind. We too are obviously opposed to these cuts for a variety of reasons. Number one, we think they are very penny wise and pound foolish. The costs of special education for blind and low vision students are extremely high. Even more so, the costs of rehabilitating youth and adults with visual impairments. These costs will definitely be dramatically increased if there are no vision services provided under the Healthy Families program. We think that we can find other funding sources. For example, although we must make sure that First Families money is spent correctly, we believe that the voters would, if they understand that there is money out there that is unspent. We think that this is the type of expenditure that, pursuant to an initiative, that they would authorize, and we hope that the legislature would consider, if these cuts can't be done away with completely, putting something on the ballot to fill the gap on a short-term basis. Finally, we are eager to work with others, including Vision Service Plan, and we hope that something can be done to ameliorate these cuts to ward off what we feel will be a disaster for those who have potential vision problems in the state. Thank you very much.
Thank you very much. If I could ask the witnesses to attempt to limit their comments to 1 minute, I'd appreciate that.
Hi, my name is Carrie Sanders with the California Pan-Ethnic Health Network and the Having Our Say Coalition. We're a statewide coalition and that works to ensure that policy solutions address the needs of communities of color, and we're really concerned about these budget cuts. We brought a couple of our members here who wanted to say a few words about the cuts.
Thank you.
Buenas tardes, mi nombre es Zenaida Ventura y yo pues soy madre de familia. Mi niña tiene 20 meses y pues a mí me va a afectar mucho si es que cortan el programa, el plan de la visión, porque mi niña apenas le detectaron algo en el ojo y eso le va a afectar mucho si es que no se lo atendemos a tiempo. También nuestro salario no es mucho para poder pagar, digamos, un especialista sin este programa. Por favor, piensen que ahorita las decisiones que van a hacer ahorita va a ser el futuro de los niños de California más adelante.
Okay, just briefly, Zenaida Ventura from Centro Binacional in Fresno. She has her children has a daughter on Healthy Families who's 20 months old, and lately found a problem with one of her eyes, and she's concerned. Without the vision coverage, she won't be able to afford to pay for a specialist to help with her eye care.
Thank you. Gracias.
Hello, my name is Jongnan Kim, and I'm a Korean American mother raising 5 kids while also working a full-time job in Los Angeles. I'm very worried about after seeing this year's budget proposal. How can the governor do political dealing with the children's health? I have always appreciated that all my kids have health insurance through Health Families. My first one is 14 years and he is 9th grade, and second one is 12 years old and he's 7th grade. They started wearing glasses in the 7th grade and they cannot read their teacher's writing on the board without glasses. We don't have television. There's nothing to do at home but read. And all my kids enjoy reading. Occasionally, I wonder if reading causes bad vision, but reading books is the only way that my kids can explore the world they never have experienced. Besides, make friends book that it's the same to have a partner in their life. Lately, I visited the eye doctor. She said that my third child will have to wear glasses sooner or later. If vision care is eliminated, I feel very bad because I cannot afford the vision care that all my kids need, especially in addition to propose the higher premiums and co-payments for the Health Families. I don't want to imagine the result, but I can guess what is going to happen. Their eyes are going to get worse, and then their achievement will get worse, and then they will lose their self-confidence.
Okay. Thank you.
Thank you very much, and please know that we're happy as a committee to accept your written testimony if you'd like to submit that.
Beth
Ms. Capel.
Beth Capel on behalf of Health Access also opposed.
Randy Hicks with Californians and Disability Rights in opposition.
Thank you. One quick question for the rep from VSP. The alternative plan that you're working on, would it look like a different benefit package? Just, where are you looking to score the savings?
We're looking at a few different alternatives, and so I don't have exact answers, but we are looking at ways of making savings to make the benefit as close as it is today as possible with some internal savings. And then we're also looking at benefit changes that would make the benefit look different and what kind of savings those would be. Okay.
Okay, because I just think the committee would be interested in knowing if the benefit package were going to change significantly.
Our goal would be that we didn't have to change it too significantly.
Excellent. With that, I would suggest that we hold this item open to allow VSP to continue to work with Mr. Mibb to see if there's a viable alternative. Moving on to issue 2. Increases to the Healthy Families Program premium.
Yes, increases to our premiums. So ever since we created this program, we've always had premiums and copays. We have had a few premium increases over the course of the past 12 years. Back in 2005, We did our very first premium increase. We did one in February of '09 and again in November of '09. This proposal before you was one that was proposed back in May revision under the prior administration. It is before you again. It will achieve savings in our program. What I would point out to this committee is that there's a couple of issues here that I'd like to bring before you. One, it is important to note that the federal government does have a 5% cost-sharing limitation. This cost-sharing limitation is everything around co-pays as well as premiums. With this increase in premiums, we will still be under that 5%. On average, we are somewhere around 4% for the families that are impacted. The other thing that is written up in this agenda is the federal maintenance of effort requirement. We talked about this back in May, and we continue to talk about it with continued uncertainty because there is no clarity from the federal perspective. There are no letters to any states that have clearly said that this is not permissible. In the write-up, there's also a discussion about Georgia, who also attempted to do this. But once again, we have looked on the federal website, and there is still no clarity by the feds where they have indicated that a premium increase in this, as presented here, is a violation. So, there is a possibility that we could go forward. It is an area that we need to explore and get clarity from the feds. So this proposal is also contingent upon, obviously, federal approval before we implement. Let's see. The other thing that I would tell you that on average, our household composition, just to put a little bit of context on this, is that in healthy families, we have an average profile of a family size of 4. We have a mom, dad, and on average, 2 children in the household. When we talk about healthy families eligibility, so that you have some context, because we always talk about federal poverty levels, a family could make up to $4,594 a month, and that is after any type of deductions that we may make on their income during the eligibility process. So with that, I leave it open for questions.
If you could, I don't know if it's best coming from you or finance, but I'm a little rusty in my federal poverty level percentages as they relate to real numbers and kind of real dollars. So can you give me, you said your average family is a family of 4, and their average annual income is?
I don't have with me their average annual. The number that I quoted, the $4,500, is the top. That's the high income bracket of 250% of poverty for a family size of 4.
That's per month?
Per month, yes.
And that's $250?
Yes.
So if I remember my numbers, 100% of poverty level for a family of 2 was like $18,000 a year. Beth says lower. Okay. I just wanted the committee to have a range, because we can quote these percentages and get caught up in that, but to really understand what that means in real dollars. And so 100% of poverty level is less than $18K a year for a family of 2. Okay.
Just on your comment about the outstanding question about the federal approval of raising the premium and copay, keeping it under 5%, have you initiated a request? You said you hadn't received any letters of guidance, but what's the projected timetable, if this were approved, to get a read from the federal government?
We are working with the administration. There are many issues between all the different agencies within Health and Human Services, and so I believe it's a joint effort to try to condense and collect all the issues that are going to be before CMS to have a conversation about that.
So I understand there's lots of other pieces than this, but so you're not able to project with any certainty what the timetable might be?
No, I understand we would like to have a budget by March 1st, and I think as we are proposing this here is that we would be looking for a legislative approval, and implementation would be contingent on federal approval up to this amount. So it could be that CMS might say those premiums are too high, but maybe if there is an interpretation that we could increase them to some level, maybe not this level, we're exploring that flexibility as well.
Mr. Chesborough.
Continuing that line of questioning, are you building in any assumption about a delay pending federal approval in terms of the impact on the cost savings?
The cost savings are tied to the assumption that there's a budget by March 1st,
But we won't have federal approval by March 1st, so...
And federal approval, correct. And so the timetable, yes, it is a moving target, and we can redo the estimate if we had a new target on when we were to assume.
With an unknown factor of federal approval time frame, it's not a fixed known savings when the savings would actually begin.
We made these assumptions based off of the best assumptions, and one of the assumptions is, in our particular case, we would need a state plan amendment, and the feds have a 90-day review time for a state plan amendment for us.
Well, to quote or paraphrase the governor, we're trying to base the budget on honest assumptions and trying to look at numbers that, unlike what we've done many times in the past, it's time to begin fessing up to this, where we intentionally adopt optimistic numbers in order to get a budget adopted. But I think one of the things that the governor's told us to do, and I would assume it's trickling down into the departments, is to try to look at real numbers as much as possible. And I know there's probably no way to predict an exact date, but making the rosiest assumption isn't necessarily the smartest thing to do either.
Tom Williams from the Department of Finance. Maybe I can shed some clarity on it too. The budget does assume a June 1st implementation date based on March 1st enactment of the trailer bill language. The administration would submit the SPA, which does allow the feds 90 days to approve, and during that time we'd also have to provide notices to the recipients and to the plans that's required. We built that in. It is the optimistic probably view in the 90 days of getting current year savings. There is language in the trailer bill this year similar to last year that says there's language that says that if the premium increases are not approved by CMS, the board may adjust the amount to the extent required to obtain approval of the SPA. So even though we have these premium levels in the statute, they ultimately, if CMS SPA approval required something less than that, the language allows the board to implement those lower levels premiums.
Go ahead.
Following in on that, if it's helpful to this committee, we have actually come up with some, you could set the premium levels at whatever you'd like, but we have another version just to so that you could see what the savings would be, if that is helpful.
If you could share that, please. While that's being distributed, I have another question in keeping with the comment on page 5 of the agenda that talks about the drop in enrollment in the 9-10 year, and really some assumptions about what could have led to that. Do you have any concerns about the role this proposed increase in the premium would play ultimately in yet another dip in your enrollment?
At this point in time, we have no data to support a caseload reduction and score savings there. We did this once, and the caseload drop did not occur. The last time that we did a premium increase, we did look at that specifically, but it was so hard to tell because we had other things going on as well. We had the premium increase, we had an increase in co-pays, we had changes in our dental selection, and when you have multiple things going on, it's kind of hard to say.
And the wait list.
And the wait lists as well too, yes.
But I would have to assume that at some point, even if we can't attribute the drop in enrollment to the 2009 rate increase, at some point we would have to recognize that multiple increases where the copay is now perhaps double or triple what a family was previously paying, could potentially have an impact on one's decision on whether to enroll or not, just based on the sheer economics. Okay, so walk us through what was just distributed, if you could, please.
Good afternoon. I'm Teresa Crum, the Deputy for Administrative Services at the Managed Risk Medical Insurance Board. And what you have before you is just some additional alternatives to the proposed premium increase. And that is showing first the current year with the top line is the current proposal, basically an increase in premiums of $14. And then right below that is 3/4 of that proposed increase, or an increase of $11, and the savings is in the far right column. And then the third alternative is if we only increase premiums by half of what's currently proposed, or $7, and it shows that savings. And then the budget year chart below that is the similar format. Just to give you an idea.
Excellent. Thank you for this. Is Finance, do you have any comment on these alternate proposals?
No, just to note as you note from the chart, it's fairly proportional, so you could pretty much, whatever percentage you want to pick, you could just apply that to the savings that are in the budget. So if you want to look at other alternatives.
LAO.
Thank you, Madam Chair. We recommend that the legislature consider a lower premium increase than as proposed by the governor, and we would note that this would have less impact on the program subscribers but achieve less in savings.
Any specific recommendation based on what was just distributed?
We don't at this time.
Okay. Any more questions of committee? I'd like to open it up to public comment and ask that you just try to keep your comments within about a minute.
Madam Chairwoman, my name is Dr. Melissa Catenacci. I'm a physician who takes care of children in San Francisco, and I want to talk to you about the impact of these increased premiums. Nearly 100% of the children I see in my clinic rely on public plans, including Healthy Families and Medi-Cal, to get the preventative care they need. One such example is one of my patients, Ashley, a 4-year-old with asthma. Last winter, she stopped coming to me because her family could no longer afford their Healthy Families premium, which had already been increased twice in the year previous. Over the next 6 months, Ashley went to the emergency room 3 times for her asthma attacks, and she was hospitalized once. These asthma attacks could have been avoided had she been able to get the preventative care she needs and keep her regular appointments with me. Increasing Healthy Families premiums will cause working families like Ashley's to delay care because they cannot afford it, shifting costs to more expensive services like emergency room and hospitalizations. The proposed cuts to Healthy Families alone will affect more than 120,000 children like Ashley and her family. We're counting on you, the state legislators, to stand up for kids and make the health of children like Ashley a priority and build a budget that protects it. Please reject the cuts to Medi-Cal and Healthy Families. Thank you.
Thank you very much for your testimony. Next witness.
Set short with children now and the 100% campaign in Pico, California. I just want to affiliate my comments with those of the physician in front of me, and also say we haven't seen the new, advocates haven't seen the new proposal proposed here today, so we're hoping that we can get a copy of that so we can provide some input and thought and guidance to that. And just one other comment, I'll just say I'm not sure this is how California really builds its healthcare system for moving forward with healthcare reform in the years ahead. Cutting away and crumbling the system that we currently have is not a good stepping stone for moving forward, so we hope you oppose these cuts. Thank you.
Thank you very much.
Beth Capel on behalf of Health Access California. We have seen this proposed increase in premiums before. Our understanding is that it does violate the maintenance of effort requirements in federal law. We think that the guidance from CMS is relatively clear on this. We're saddened to hear that the administration and Mr. Mibb are still confused about this. So we would urge that this legislature not book these savings, because we believe that this cut, in particular the increase in premium, is a change in eligibility methods and procedures, and that the CMS has been relatively precise about that. Thank you.
Thank you.
Thank you, Madam Chair, members of the committee. Carolyn Jenna with the California Medical Association. We too would urge the committee to reject this proposal that has been brought forth last year as well. Families on the Healthy Families program the last couple of years have seen multiple increases in premiums, and as a fundamental question of policy, California's physicians support Californians being able to have some type of coverage, and we really fear that given the level of the increases included in this proposal, we will just price a lot of people out of having any coverage at all. Thank you.
Thank you. Next witness.
Vanessa Kahina with the Western Center on Law and Poverty. I'd like to associate my comments with those of Ms. Capel in terms of what the spirit of the MOE really means for maintaining eligibility. Clearly, this is not affordable for working poor families. If you're talking about a family between 150 and 250% of federal poverty guidelines, $126 a month is a real non-starter for these families. As a result of that, we ask you to ultimately reject this proposal.
Thank you.
Good morning, Chair and members. Allison Ramey on behalf of the California Primary Care Association, representing the over 800 nonprofit community clinics and health centers in California. Our member clinics serve roughly 200,000 of the children on healthy families. And for the reasons stated before me, we are opposed to both the premiums and copays simply because they will price children and families out of this wonderful program. Thank you.
Thank you.
Madam Chair and members, Tim Shannon representing the Children's Specialty Care Coalition. This is a group of 2,000 pediatric subspecialists that treat kids with the sickest conditions in the state, those that are in the CCS program. By law, children in CCS are deemed eligible for healthy families. This will have a particularly hard impact on them because these kids have the most serious conditions: cancer, cystic fibrosis, congenital heart disease. We urge you to reject these for reasons previously stated. Thank you.
Thank you. Next witness.
Madam Chair and members, Sharita Lane with the California Children's Hospital Association. We also urge you to reject these for the reasons stated prior. Thank you.
Carrie Sanders with CPEN, having our Say Coalition, also urge you to reject the premium increases. It will have a huge impact on the communities that we represent. It's almost a doubling of their premium prices after, they've already seen increases in the past, and basically will put healthcare out of their reach. And so we're really concerned about this and urge you to consider other alternatives. Thanks.
Kristen here on behalf of the California Academy of Family Physicians and the Osteopathic Physicians and Surgeons of California. We oppose the premium increases as well as the copays and worry that it'll increase the use of emergency rooms. So we respectfully oppose the proposal.
Thank you. Any additional questions from committee members? It's the committee's recommendation that we hold this item open. Moving on to a related issue, issue 3, increases to the Healthy Families co-payments.
Yes, Madam Chair, the increase to the Healthy Families co-payments proposal is a conforming proposal. With that in the Medi-Cal program, we would propose to increase our co-pays for the use of the emergency room when it did not result in hospitalization from $15 to $50. And we are proposing to have a hospital inpatient copay of $100 a day with a $200 maximum per stay. I would say in response to this proposal that in the Healthy Families program we also have statute and regulations that actually address the family's maximum copay out-of-pocket expenses to be $250 annually per benefit year, and that is per family, not per child. So whereas these increases are conforming to that of the Medi-Cal program, there is a cap, an annual cap, so that families do not exceed the 5% threshold as required by the feds.
Finance.
Yes, we would just note that this proposal does conform to Medi-Cal, and the implementation date that's given of October 1st, 2011 takes into consideration on the Medi-Cal side, they would need a waiver to implement this. On Healthy Families, it's a SPA, but the longer implementation compared to Vision is to account for the fact that Medi-Cal would need a waiver, which takes a little longer.
LAL.
Thank you, Madam Chair. We are recommending that the legislature consider a lower copayment amount than is proposed. We also further recommend that the legislature consider these copayment amounts in tandem with the Medi-Cal program to ensure consistency between the two programs.
I thought you were going to say in tandem with the premium increase. Okay. Any questions of committee members? Yes, sir. Ms. Mansour.
Has there been any assessment of the cost to doctors in terms of administrative costs for collecting the copay? Is it going to cost more for them to administer it than they're actually going to be receiving?
Well, in the emergency room, we already have a copay. It's
I'm talking about at the doctor's office.
Both of these, one is for the emergency room,
Okay.
and the other is for inpatient hospitalization.
Okay. But in the emergency room, the proposal is an increase?
Yes.
Okay. What if the person doesn't pay or doesn't have the money? The emergency room still treats them, correct?
I believe the answer is yes, relative to the requirements, the regulatory requirements that hospitals comply with for all people, all individuals that come to their emergency room door.
Thank you.
We'll open up to public comment. Ask that you keep it within a minute. Ms. Capel.
Yes, Madam Chair. Beth Capel on behalf of Health Access California. We would commend to the administration a reading of the federal requirements, which say that it cannot exceed 5% per enrollee in a month. $250 is well in excess of that for these families. It also requires that the burden is on the state agency to track the copays and cost sharing, not on the families. It is quite plain with respect to that. So we would suggest that this proposal, like the prior one, is not consistent with federal requirements, as well as being bad otherwise.
I missed the last line. What'd she say?
Tough act to follow.
Okay.
Madam
Would
Chair.
you like to respond not to the last comment, but to the
Like I said, that's a
previous
tough act to
claim?
follow.
Yeah.
One quick second. I wanted the department to respond. I saw a furrowed brow.
Yes, thank you, Madam Chair. What I actually said was the $250 cap is per family per benefit year, not per month.
And the federal requirements are on a monthly or at the most quarterly basis. And so $250, with this proposal, a family could spend well in excess of 5% of their income in a month if a child is hospitalized.
And therefore more within a year.
Indeed.
Got it. All right. Thank you. Next witness.
Thank you, Madam Chair, members of the committee. Carolyn Jenna with the California Medical Association. California's physicians are opposed to this proposal as well, given the many comments made prior to mine. Would like to thank the chair as well as Mr. Chesbrough and Mr. Mansour for your comments about the cumulative effect of both increasing copays, increasing premiums, and what that does on the ground to these enrollees and their ability to access care, and whether or not we're going to be driving more into the emergency room. Thank you.
Thank you.
Madam Chair and members, Vanessa Kahina with the Western Center on Law and Poverty. Glad to see that you got our federal poverty guidelines, and happy to go and make more copies for the rest of the members of the committee. Another clearly unaffordable proposal for California's working poor families. For that reason, we oppose.
Madam Chair, members, Sharita Lane with the California Children's Hospital Association, and like the speakers before me, we are also opposed to this because we're very concerned about the cost to the families, and also, as mentioned, the burden on providers that in collecting the co-payments. Thank you.
Randy Hicks, California's Disability Rights. I'll tell a personal story here of a friend of mine. He just lost his job. His son is 2 years old. And what's happening is they're on both Healthy Families and Medi-Cal. And what's going to happen is that his wife wants to go to school so she can get a better job. And she's living on student loans and grants and so on and so forth. The problem of it is he wants to be a stay-at-home dad. So he's going to try to get his own home business. But until then, now that you're increasing both the premiums and the co-pays, it's going to be very hard for them to get their son in to see a doctor. It's all about preventive medicine. If they do not get him into a doctor in time, they're going to miss something. He's supposed to have regular checkups, regular immunizations, and because of this, it's barring them from the door, and they'll end up in an emergency room visit because of what's going to happen, because of these increases, and because of the copays. Copays have always barred people from getting medical care, whether you're on Medi-Cal, whether you're on Healthy Families, or whether you're on any kind of program. It says that money, you have to come out of your pocket. You go there, you don't have the money in your pocket. What are they going to do if they don't have it?
Thank you. Appreciate it. Next witness.
Madam Chair, members, once again, Tim Shannon for the Children's Specialty Care Coalition. We oppose these copays. We'll have more to say about them when you discuss them with regard to the Medi-Cal program. Once again, our physicians treat the sickest kids. They have more doctor visits, more emergency room visits, and more hospitalizations. So we urge you to reject it. Thank you.
Thank you. Next witness.
Set Short, the 100% campaign in Pico, California, also opposed. I just want to highlight the fact that this proposal in particular inordinately negatively impacts our sickest children, our children with chronic illnesses, and we urge your opposition.
Thank you. Next witness.
I'm Joel Cohen with the Center for Oral Health, and we oppose for all the reasons everyone else has suggested. Thank you.
Thank you.
Mary Sanders, CPEN having our say, also opposed for the reasons already mentioned, and I just want to leave a couple letters that deal with both the premiums and the copay increases. So,
please, thank you.
Tim Madden, representing the California chapter of the American College of Emergency Physicians, were opposed to these cuts. Our concerns are such with the raise in the copays, it'll actually cause these patients who may think they're having an emergency condition to hold off from going to the emergency department. To the extent that they wait just for the reason that they can't afford the copay, only worsens their conditions, which leads to poorer outcomes. We ask you to reject this measure. Thank you.
Thank you. Next witness.
Peter Gamby on behalf of the Association of California Healthcare Districts. ACHD is opposed for reasons previously stated, and because we are concerned that these copays will serve as effectively a rate cut for providers, putting further pressure on providers, healthcare providers that are extremely short supply in the communities we serve, and will force more physicians to drop out of the program. Thank you.
Thank you. Mr. Chesborough.
That raises an interesting question. Does the requirement for copay also lower the reimbursement in a way that the money is actually intended to backfill them for the lower reimbursement? Is that what's happening here?
The way the state achieves the savings is a reduction in the capitation that's paid to the health plans.
And then the assumption is that they recover some portion of it with the copay. Okay. I just want to make sure that's clear. Thanks.
Any other questions? It's the chair's recommendation that we hold this item open. We'll move on to issue 4, the final issue for Mr. Mibb, pre-existing condition insurance program request.
Yes, Madam Chair, we have before you a proposal to authorize our positions for the PSIP program. This is a program that we have brought up very quickly as of October 25th of last year. It is 100% federally funded, and it is a short-term program whereby we will administer this high-risk pool on behalf of the federal government through through June of 2014.
Is there any general fund impact finance?
No, there's, in fact, the enabling legislation prohibits the use of general fund in the PSIP program.
LAO?
We recommend approval of this proposal and would note that the Senate approved this as well.
Any questions from the committee? Ms. Capel.
Beth Capel on behalf of Health Access California. We were pleased to have worked with the authors of this measure that enacted this measure, Mr. Valines and the other legislators who were involved in the bipartisan effort to create this. We have been saddened by the abject failure of Mr. Mibb to advertise the availability of this program during the months during which they have been bringing the program live. This is an important service to Californians, and we would hope they would let Californians know.
With that, it's the chair's recommendation that we approve as budgeted. I'll entertain a motion.
So moved. Second.
Roll call.
Mitchell.
Aye.
Chesborough.
Aye.
Jeffries. Jeffries.
Off.
Mansour. Monning.
Aye. 3 ayes. That measures passes out. Thank you, Mr. Mibb. Appreciate it. We'll move on to Section 4250, which is the California Children and Families Program. Issue 1, Prop 10 Fund Shift to Medi-Cal. Thank you. Okay, I see finance, I see LAO. So we don't have anybody coming from. I think so. Ms. Novick, with the two empty chairs in the middle, why don't you come forward? And so why don't we have you? No. So finance, yeah. It took me a minute to kind of, okay, missing people in the middle. Okay, so if finance would present the finances proposal.
Thank you, Madam Chair, Assembly members. My name is Robert Decay with the Department of Finance. This budget proposal is kind of a two-parter, so I'll kind of break it up into two. The agenda goes into pretty good detail about the history of Prop 10, so I'll just kind of get into the proposal. For the budget year, the attempt is to address the $25+ billion shortfall, and then starting in 12-13, there's a proposal to address the ongoing structural deficit by reducing the overall state spending. So in 11-12, the proposal is to use $1 billion in state and local Prop 10 reserves to fund Medi-Cal services for children ages 0 through 5, and this will allow for the continued funding of early childhood health core programs in the health arena. And then starting in 12-13 and going forward, after the backfill and other adjustments that are taken from Prop 10 revenue, 50% of the Prop 10 revenue will be deposited into a newly established account and to be allocated for programs that serve children ages 0 through 5. And then the remaining 50% will be distributed under the current schedule of 80% going to the local commissions and 20% to the state. This proposal is subject to voter approval. And the target right now in the governor's budget, the proposal was roughly $234 million to come from the state finances and the $766 to come from locals. Recent developments: the state commission voted last week to fund $50 million to DDS and I believe it's $73 million to Mr. Mib for a total of $133 million in the current year. So the governor's budget at the time of $234 million is going to have to be adjusted down. Right now, we're still kind of working out where they're going to land. Therefore, right now, as far as language is concerned, we haven't really nailed it down. At this point, we're presenting a range, but once we kind of figured that out, we'll be happy to share it with the members and the public.
And do you know if the state commission plans to take any further actions that could further complicate you identifying a realistic target?
There's still a budget year solution for DDS of $50 million that's looming, that we don't have a secure understanding of where it will come from. The idea is if the state commission can, it'll work from there, but also there is the option for the Department of Developmental Services to work with local Prop 10 commissions to see if they would also like to opt in to adjust that $50 million as well.
LAO.
Christine Fry, Legislative Analyst's Office. We concur with the governor's proposal and would note that given the state's fiscal condition, the legislature might want to consider redirecting additional money than what's been proposed.
Mr. Chesborough.
As you know, we, in attempting to do something like this last year, placed a measure on the ballot and asked the voters, can you address either finance or the LAO the legislative or the requirements of the initiative relative to the legislature's ability to do this without or zero requirement for a vote of the people?
My understanding is that it will require voter approval since it was a voter-approved initiative back in 1999.
So it's anticipated that there will be a ballot measure in June?
Correct.
Do this? Okay, thank you.
Ms. Novick.
Thank you, Madam Chair. members. I'm Sherry Novick with the First Five Association of County Commissions. I represent the 58 county commissions. I've supplied you with a little handout. I just thought I could give you a little background information so you can understand the impact of this proposal. If you look at the chart at the top on the front yellow page, you'll see the components of the fund balance. This is all based on audited numbers from the last fiscal year as of June 30th, 2010. You can see that the number of that 1.9 that you see in the total fund balance, almost 50%, 48.8%, is what they call, what auditors refer to as reserved, meaning legally obligated dollars. The next column, unreserved designated, are dollars that commissions have allocated but were not yet in contract. They have to meet a fairly high standard in order to fit into that column, which you can see defined further down on the page. The last column, the 18.5%, those were the unreserved, undesignated funds that auditors determined were not committed to anything. Now, in thinking about what the impact would be on local communities, the reserved and unreserved but designated pots are the pots of money that counties, departments, and hundreds of CBOs, community-based organizations, are counting on to provide services. So we did an analysis, and if you look at the back of that front page, the yellow page, we did an analysis of where those reserved and designated funds would be going, and you can see the list of services that they're dedicated to. These are all pursuant to well-developed county, legally required strategic plans, plans that are audited as well. So essentially, a sweep of the county fund balances would potentially force termination of contracts in any or all of these areas, depending on the amount of money that we would try to take from the county commissions, because we're referring to fund balances, not necessarily reserves. These are not necessarily dollars that are just in a slush fund. They're actually dollars that that are planned for. Just a couple points I would make that are under this other facts to consider. County commissions operate with a declining funding stream. Since the inception of Prop 10, the revenues have dropped almost 30%, which is a good thing because it means smoking is declining, which we're promoting, obviously. So what county commissions do is they dip into their fund balance to continue to sustain programs. And in fact, last year they spent more than they brought in, because they are now in the phase of dipping into their fund balances to keep programs running. They also make up for the loss of revenues by leveraging funds. On the front of the blue sheet, you can see this is our most recent survey of federal funds that were leveraged with Prop 10 funds. These are dollars that were brought in solely because Prop 10 funds were there to provide a match, and those dollars came into county coffers, into county programs, generally through county agencies. We also work very hard, and increasingly so, leveraging private dollars. And the back of the blue sheet demonstrates an analysis from two of the Bay Area and the Southern California regions to see, so you can start to see how they've been able to leverage. In other words, they're using their funds to help entice private funders to put their dollars together and operate more efficiently. The last sheet here on the front of the orange sheet on the back of your packet shows the number of children served just last year, to give you a sense of where the money went last year. And if you flip it over, it shows how county commissions are shifting some of their funding priorities in order to address the services that have been cut through state budgets the last 3 years, and just what's happening in communities because of the recession and increasing needs. To the extent there is still black infant health in many of our counties or pediatric oral health services, it is because of First Five funding, where it's the primary or, in many cases, the sole funder. We are seeing more dollars going into shelters, food banks, basic needs for families, including the newly poor and others, actually, who are not eligible for state programs. So we would argue that essentially this proposal, the combination of taking from what is already there and planned for and reducing by half all future funds, the combination is essentially taking from families and young children in need whose needs are being met locally right now in order to dump some funding into the general fund. And as we know, the Department of Finance calls for those dollars to go to Medi-Cal, but it's really to the general fund. That's fungible. It's plugging a hole in the general fund. We understand the need for that. We want to help. We want to be part of the solution. But we would submit that this particular proposal is disproportionately hurtful to these programs and these children. And so we would ask that, that the legislature help us to rethink this proposal and consider some alternatives.
LAO.
We have no further comments.
I want to make sure I'm clear, Ms. Novick. So we're in the agenda. It states that finances plan, the $1 billion, $766 million would come from the local commission reserves, and the yellow sheet suggests that the only unreserved, undesignated dollars available is closer to $354 million, so less than half.
This is as of last June 30th, and actually it sounded from Department of Finance like they actually would now assume that a greater proportion would have to come from the counties.
I got that. I just wanted to get a sense of what the difference is currently as it reflected in the proposal. Any other questions? Ms. Yamada.
Thank you, Madam Chair, and again, thank you for allowing me to guest here. I just wanted to be sure, this is an orange sheet and your sheet looks pink. Is it the same?
Because I ran out of orange.
Oh, okay. I just wanted to be sure we were on the same color page. Thank you.
Any other questions of committee members? We're going to open it up to public comment. I'm going to use my handy-dandy timer to really try to encourage everybody to stay within a minute, and I'll give you a 10-second heads up. First witness.
Thank you, Madam Chair and members. My name is Fred Noteware. I represent the California Dental Association. The CDA opposes this proposal for a variety of reasons, but not the least of which, as this committee well knows, there's been the demise of the adult dental program as well as the elimination of the California Children's Dental Disease Prevention Program, and there's very little left now for dental care, particularly for children in California. As Sherry pointed out, these funds are especially helpful at the local level because, again, there's very little left. Look forward to working with this committee, but we have to oppose this very aggressive proposal. Thank you.
Thank you, Mr. Noteware. Next witness.
Yvette Alada on behalf of the Coalition of Orange County Community Health Centers and the 22 community health centers that we represent and our 225,000 patients. Many of the beneficiaries of the first 5 programs and services throughout our county and state fall under 133% of the federal poverty guidelines, which means they qualify for no-cost Medi-Cal. However, there is a significant number of children and families with incomes between 134% to 200% of the federal poverty level, and it is this cohort of children that the Children and Families Commission dollars provide vital health services and care for. The loss of $1 billion from First 5 would mean that this segment of the population would be at risk for not receiving health care because these families, who are already struggling to make ends meet as it is, would have to pay added high out-of-pocket rates for health services or just be left without medical services altogether.
10 seconds.
And that's it. Thank you very much.
Thank you very much. Next witness.
I'm Joel Cohen with the Center for Oral Health. As was previously stated, the concept of oral health in our state and its programs really have declined over the last few years. The first 5 commissions last year provided 133,780 kids with preventive care. You might think, well, what does this mean? It means if these kids did not have the care, then they probably would not be able to get into kindergarten and be healthy and do that. In addition, we know that large amounts were spent, and it's not just like the money would come from some other place. So truly, the funds used in First 5, really, this is the only pot. The programs are vital, they're efficient, and they're community-based. Thank you very much.
Thank you. Next witness.
Good afternoon, Madam Chair and members of the Assembly Budget Committee. Thank you for the opportunity to speak before you today. My name is Lynn Hoffman, and I'm staff to the First 5 Solano Commission. I'd like to urge you to rethink this proposal to shift Prop 10 funds. In Solano County, we live on our combined local trust fund as well as our annual income. Therefore, the fund shift would not only be a cut, it would devastate some of our existing programs. In Solano County, 96% of children are currently insured, 500 of which would lose coverage if this fund shift occurred. There are no other funds out there to pay for these children. In addition, there are other potential losses. With First 5 Solano, we leverage almost $2 for every dollar. Therefore, every dollar we spend, $2 goes to the community. In addition, we leverage federal dollars. If the Prop 10 funds were shifted, we could potentially lose our EPSDT and nurse partnership programs. Furthermore, Solano County is one of the best models for realignment. We currently work with our cities, our counties, our school districts, and our community-based
10 seconds.
organizations. We urge you to oppose this and rethink the shift. Thank you for your time.
Thank you. Next witness.
Good afternoon, Madam Chair and members of this committee. My name is Elena Stern, and I work for Para Los Niños. Para Los Niños is an LA-based nonprofit that for 30 years has been providing high-quality education, mental health, and family services in high-poverty areas of Los Angeles and Ontario. Two of our biggest funders are First 5 Los Angeles and First 5 San Bernardino. For 2 years, we have been carrying on or leading an effort funded by First 5 Los Angeles that is its first place-based effort, prevention effort in the LA community, Metro Los Angeles. It's called Best Start Los Angeles. It is an effort that brings together parents, businesses, and community leaders to transform neighborhoods into places where young children can grow up to be safe, happy, and healthy. Through Best Start's Welcome Baby program, we're already seeing success. Hundreds of infants and parents are receiving disease prevention and education programs that are so vitally needed. This is a community of great promise, but very high need. First 5 Los Angeles made a long-term commitment to this community because of the challenges that it faces. These are challenges that cannot be addressed in a single year, hence the long-term commitment.
10 seconds.
If First 5 LA's funding is cut, these children will not see the future that they so richly deserve. Thank you.
Thank you. I have a quick question because you talking about Best Start just triggered for me. So as we talk about this total unreserved designated pot, Ms. Novick, using the last witness as an example, since those are dollars that have already been allocated, and I'm assuming First Prop 10 is funding them multiple years, wouldn't that be captured in your unreserved designated column?
Largely. If some of those dollars may already be in contract, I imagine there's a contract with Para Los Niños that would be in the first column. So the same program is actually in both columns.
So what's really at risk if this proposal passes are perhaps not programs like we just heard about, because those commitments that have already been made and those dollars are identified in the unreserved designated pot. Finance is nodding yes. I just want to make sure I understand, as we hear from the witnesses, to really be able to discern kind of what programs will continue to be funded, what are at risk giving this proposal.
We've had recent data that shows that from 0809 to 910 that local commissions only spent down $110 million on a year over year. Ms. Novick explained that they're spending more now than they had. So this total reserved, while it might be encumbered in contracts, I think it's important to note it's not encumbered in contracts in 11-12. And in 12-13 and ongoing, while their revenue might have been cut in half, we're just basically, I don't want to, the administration isn't trying to indicate that these programs aren't valuable. We're really just asking that for the voters to look at the possibility of reprioritizing their spending, given our situation.
But Madam Chair, there are multi-year contracts.
Right.
So they are encumbered in future years. But we could break contracts. The contracts can be broken. I just think that the committee and the legislature needs to understand that it would entail breaking contracts to get that amount of money.
I understood that. I know Best Start is a multi-year contract. That's why I was just trying to figure out if, because it's a multi-year contract, those dollars are quote-unquote protected as it's reflected on your chart or not.
I would think some are certainly in the reserved, and no doubt, because it's multi-year, there are some that are not yet in contract.
Got it. Thank you. Next witness, please. Sorry for the interruption.
Good afternoon. My name is Gisela Gutierrez, and I'm coming here as the parent representative and the chair of the community guidance body within the Best Start Metro LA initiative. And I'm coming here in representation of hundreds of parents that have already committed to being part and taking leadership roles within this initiative. Parents who have organized themselves and have been empowered to make a difference within a community that once lost hope. We have over 85 agencies who have also committed in being involved with this initiative, from a supporting role to service, rendering services, so on and so forth. And a lot of movement has already been made where parents themselves have already identified the problems within our community, such as a lack of child care centers for young children, school readiness programs, or parent education and skills development workshops for parents. These are problems that if you invest in them now, it will prevent bigger issues such as dropout rates and the high number of child abuse cases that we see on a day-to-day basis, as well as more families depending on public assistance. So I ask you to please reconsider this proposal and realize that an initiative like Best Start Metro LA brings the resiliency and the autonomy that a community like mine is in need of. Thank you.
Thank you very much.
Hi, good afternoon. My name is Emily Peary, and I'm here just as a concerned parent. I want to thank you for the opportunity to voice my opposition to this budget proposal, which affects First 5 LA funding. First 5 LA funds my son Jonas's preschool program, is LA Universal Preschool. And this program has been a huge blessing to my family. My husband lost his job last year, which he had had over 10 years. We had to look at our budget to see what we had to cut to make ends meet until we could get back on our feet. Preschool has always been a priority to us because we know, as you know, that it provides a great foundation to not only to their education but also just success as adults. We couldn't afford it, and we couldn't qualify for Head Start or other state-funded preschool programs. We were excited when we discovered LA Up through a friend. When Jonas started LA Up, I was just impressed with how well it was organized and how great the teachers were and how they had so many parent education opportunities, and that it provided education. Also, they also provide accountability for their students, where my son was assessed.
10 seconds.
Okay, thank you. I just recommend that you reject this proposal so my younger son can also be a part of that program, as well as all the other children that are in LA County that are in the same situation as I am. Thank you for your time.
Thank you for coming. Next witness.
Hello, my name is Vincent Waller, and I also am a parent of a LA Up student. And I'm here to voice opposition to the redirection of the Prop 10 funds away from the LA First 5 commissions. Right now I have my oldest son who's 4 years old, and he's in an LA Up program, and he really enjoys it. It seems to be one of the highlights of his day. He enjoys attending school. His desire to learn has increased, as well as just his overall being able to share with other students, other kids. As a sole provider for our family, without the funding from the First 5 commissions, my son wouldn't be as far advanced in his education as he is today. I have a second son, 3 years old, who next year is scheduled to attend LA Up, and I'm really looking forward to him being able to participate in the same things that his older brother has. Governor Brown has stated that he's protecting education because he considered it a civil rights issue. And so along those same lines, I hope that you guys can leave the funding for First 5 LA in place. Thank you very much.
Thank you very much. Next witness.
Chair Mitchell and honored members, good afternoon. My name is Cindy Chandler. I'm the Executive Director of a Family Resource Center, a Prop 10 provider in Sutter County. I'm here to speak from a parent perspective, though. At 4, our daughter Emily was nonverbal along with other signs of autism spectrum disorder. Miracles do happen, but in our case, not without dedicated programs and educators. It is scientifically based. It's a fact that early intervention, 0 to 5, is crucial for children with disabilities to reach their full potential. The journey with a child with disabilities is not an easy one, and we tell parents, don't do this alone. We're here to help, to listen, and give you the information and the confidence you need to be the best advocate for your child. Parents supported by Prop 10 funds are well prepared to navigate the myriad of systems of CCS, Regional Center, IHSS, SSI, IEPs, IFSPs, IPPs, waivers, deeming, and so on. So if you don't recognize all of the alphabet soup,
10 seconds.
Neither do parents. But their outcome depends on that knowledge, and Prop 10 funds and their programs help them meet those needs. Thank you.
Thank you.
Hi, good afternoon, subcommittee chair people. My name is Mary Pickering. I'm a licensed clinical social worker, and I'm also with Family Resource Center in Sutter County. The governor and other knowledgeable, well-meaning people are calling for effective, efficient, needs-assessed, locally controlled, innovative, and non-duplicated programs to help the citizens of our state, particularly the young children ages 0 to 5. Prop 10 funding encourages and allows these programs to be developed and implemented in the counties where they're needed. So I urge you to oppose the current proposal to redirect funding, or if it does come down to putting it on the ballot, please do not put it on the ballot. Thank you.
Thank you. Next witness.
Thank you for allowing me to speak for the children. I am Bishop Henry Hearns, and also the former mayor of the city of Lancaster. We're located just 60 miles north of Los Angeles, about 450,000 people there, and of that, about 60% of this is minority. In 2002, the county issued a grant, $221,000, to reduce African American infant mortality rate from 39%. Due to state budget, this was cut in 2008. First Five came to the rescue to the children for 2 years with the hope that the state would continue. But when it did not, First Five again rose to the occasion and gave us 3 years more to help. And by the help of God and First Five, we've been able to reduce this to less than 15%.
10 seconds.
I'd like to leave this statement, and we'll drop the rest that I was going to say, and that is this, the old statement that you can pay me now, pay me later. And I'd like to say, pay me later won't work, because the product, the children, will have exceeded their shelf life and gone unprepared. So I urge you to pay me now. Leave First Five to do its job to get our children where they need to be. Thank you very much.
Thank you very much for your testimony. Next witness.
Good afternoon. My name is Angelica Perez, and I am the Parenting Program Manager from Centro La Familia. Centro La Familia Advocacy Services service low-income families throughout the Fresno County. Centro La Familia is a member of the California Resource Association and receives funding through First Five Fresno to conduct the Que Significa Ser Padres parenting program. Both programs being held in Huron, in the communities of Huron and Mendota. Centro La Familia, through this grant, serves 60 parents and 110 children, increasing parenting skills by an 83% and school readiness in children by 81%. This program is designed to strengthen positive parenting skills and to reinforce the fact that parents are the child's first teacher. And together with me, I brought two parents from both Huron that would like to comment.
Thank you very much. Keep it under a minute, please.
Mi nombre es Roselia Madera y soy una de las 20 padres de familia del Centro de la Familia, apoyado por los primeros 5, y solo para apoyar a este programa, esta asociación que ha ayudado mucho a nuestra comunidad, que es de bajos recursos, y con estos programas hemos ayudado a varias personas más simplemente a ser mejores padres para nuestros hijos, y sabemos también que la educación es la principal para el futuro de nuestros hijos, y queremos seguir apoyando estos centros de apoyo, que las comunidades rurales que están alejadas de las capitales, centros grandes, están olvidadas, especialmente por que nunca nos visitan o no sé, pero sí queremos alzar nuestra voz y decir que estamos ahí presentes y que ocupamos las ayudas de muchos centros, y sabemos que el futuro de nuestros hijos es el mejor, y lo mejor para enseñarles a nuestros hijos es la educación.
10 seconds.
Thank you very much.
Just really quick, she just was saying how the program has impacted her, that she wishes to bring more programs into the community, and that they have learned a lot through the program.
Thank you.
Mi nombre es Patricia Martínez y soy un miembro del Centro de la Familia, Asociación de Padres de Familia, que el Centro de Familia ofrece con fondos de primeros 5, y el Centro de la Familia es un miembro de Asociación de CEFRA y me ha ayudado a desenvolverme como madre para poder ayudar a mis hijos a llegar a la escuela, para poder que salgan adelante en su futuro y conocer los diferentes recursos de mi comunidad. Gracias.
She basically said that the program has helped her to learn how to prepare her children for school, and that it also has bring a lot of awareness on the community resources that a small community has in her surroundings. Thank you.
Thank you very much. Next witness.
Good afternoon, Adam Sonnenschein with Los Angeles Universal Preschool. We're a nonprofit organization with the mission of increasing access to high-quality preschool. You've heard from two of the parents of our 10,000 children who are attending quality preschools that are funded almost exclusively with dollars from the First Five system. Just want to point out also that in addition to the benefits to the families and the children, we're also supporting jobs for over 1,000 teachers in all of these programs, and those jobs are put directly at risk by this proposal. These programs that are funded by First Five are working, they're needed. I urge you to let them continue and urge you to reject this proposal. Thank you.
Thank you. Next witness.
Good afternoon. My name is Carla Brody. I'm a child development specialist at Parent University. It's a First Five funded resource center located in Hunters Point in San Francisco. And it's one of the most marginalized neighborhoods in San Francisco. Families that frequent our center face a range of issues, including extreme poverty, environmental health issues, community violence, and young children are impacted the most. Last year's statistics show that children from Hunters Point significantly improved their kindergarten readiness, and parents increased their literacy with their children. I'm really urging you to reconsider this cut. These proposed First Five cuts will directly impact already vulnerable children at the most critical time in their lives, and long-term effects will be irreversible and detrimental to the state as a whole. Thank you.
Thank you very much. Next witness.
Good afternoon, Madam Chair and Committee. I'm Jenny McTackett, also from Parent University. The simple goal of Parent University is that every child living in the 138 families in this public housing project is ready to enter kindergarten. And in addition to our strong school readiness results, we've screened over 100 children and linked them with a permanent health care home. And we've provided a range of evidence-based parent education programs. We know that everyone in California has to share the pain of a responsible budget, but this is a budget that's going to decimate the programs that help the children and families who need them the most. And so on behalf of the 138 families, we ask you to reconsider the harshness of this proposal. Thank you.
Thank you very much. Next witness.
Good afternoon, Madam Chairperson and Assembly members. My name is Cheryl Gully. I'm an LCSW and Program Director for Special Needs Network located in South Los Angeles. We are the only agency in South Los Angeles that services children who are impacted by autism and developmental disabilities, and we are here to urge you to reconsider any cut in funding to First Five, because if you do, it would truly devastate us in our ability to provide services to over 500 families that we do service. Thank you.
Thank you.
Good afternoon, Madam Chair and members. My name is Lisette Duarte, and we are here from the Special Needs Network in support of First Five LA. I am a parent of two children, one of whom has special needs. Raising a typical child can be very challenging, but raising a child with special needs is very difficult. First Five LA has funded programs for the Special Needs Network that have given me the tools to empower myself, to self-advocate, help my family, and also help my community. I have become more actively involved in the many arenas which my special needs child intersects. By cutting First Five funding, you will also cut services to those most vulnerable in our society. With the current reduction in programs and resources available to low-income families, any further cuts would drastically impact how our children and families are able to participate in communities in a healthy way. So I urge you to continue to fund First Five so that we can send the message that California's children and families matter. Thank you.
Thank you.
Madam Chair, Ray Jones, representing Great Beginnings for Black Babies in Los Angeles, which was founded 20 years ago to combat infant mortality. And since 1989, the Black Infant Health Program, our largest program, has worked to improve infant mortality in the African American community, and we have. Research shows that the thousands of women who've gone through our program fare much better in healthier birth outcomes, but there is still much more work to be done. African American babies are dying at 3 to 4 times the rate of any other ethnic group in this country. 2 years ago, Black infant health was cut from the state budget. After a serious appeal to First Five, they funded the program. Just 3 weeks ago, First Five LA agreed to fund Black infant health through 2014. We have a commitment, but not a contract. We need that commitment to be honored. Black babies are still dying, and we still have much work to do. Thank you.
Thank you.
Madam Chair and members, Monica Miller on behalf of the Nurse Family Partnership Program, and First Five is actually a major funder of our program. We are an evidence-based program. We've been around for about 30 years. We capture young women, first trimester, first baby, and are able to take them through age 2 of the baby's birth. We break the silence of domestic violence, drug and alcohol abuse. Most women go on to not only get a high school diploma, but also a college degree, and so do their children. We keep them out of foster care, out of juvenile hall, and out of prison. So it's a really critical program, and we need this funding to keep going. So thank you.
Thank you.
Good afternoon. I'm Deborah Brownstone from Project SAFE at the Help Group. We're part of the Partnership for Families initiative funded by First Five LA, and I urge you to maintain First Five funding, as we've been able to effectively serve over 700 families with in-home services and thousands of families through community-based education workshops and activities geared to building strong, healthy families in the San Fernando Valley. And I think that First Five funding is a real example of where government got it right and is providing effective, collaborative, replicable services that our evaluation shows significantly reduces the re-referral rate for families that we serve to the Department of Children and Family Services. And on behalf of the Help Group, I urge you to maintain First Five funding.
Thank you. Next witness.
My name is Veronica Ardolino, and I'm a parent who's received services through First Five and Project SAFE. After referral to DCFS, I received in-home services for 6 months from Project SAFE, as well as parenting classes, financial literacy, leadership, so many other benefits that have really improved my relationship with my children. And I think that First Five is able to target their money to the families that need it the most and the children who need it the most, and I encourage you to continue to fund them. Thank you.
Thank you for your testimony. Next witness.
Madam Chair, committee members, I'm Dr. Catherine Eisenhower. I'm the Director of Shields for Families in South Los Angeles. I'm here also representing the Partnership for Families program, specifically in our area, the Achieving Change Together program. I wanted to remind the committee that the voters, when they put this initiative on the ballot years ago, did it to serve vulnerable families and children, and that last year they told you again that they wanted to continue to serve vulnerable children and families. And I would like you to make sure that that money stays in its place. You will not find our program in that committed, contracted money, because in Los Angeles we were targeting to move our programs to Best Start communities. So those services have not been committed or contracted out, which essentially means all the safety net services in the South Los Angeles area that are funded through First Five right now are pretty much going to be eliminated if this doesn't continue to be funded through this budget. So again, I bought some materials for the committee, which I'll leave here, and thank you for your time.
Thank you. Next witness.
Yes, hi, good afternoon. My name is Tequila Sorrells, and I'm a participant of the Shields for ACT program. And I was born and raised in a joint down housing projects, and I've seen programs come and go. Unfortunately, I was blessed to have attended Dillard University in New Orleans and have completed 2 years. But I had to come back to support my family, for the death of 2 of my brothers, and, I have 2 best friends who are struggling raising their child without fathers, which one was just murdered on Christmas. Thanks to the Shields for Family Act program, it has helped me mentally, emotionally, it has helped me cope with the death and to overcome with the death of my brothers. Now it built my self-esteem. I have found self-worth not for only myself, but for my child. I have a 5-year-old. And, in our community, we highly value programs like this, and it would be detrimental to really take it away. So we really need these programs in our community. Thank you.
Thank you very much. Next witness.
Nisette Short with Children Now. Children Now really values these locally driven social service programs, health programs, dental programs, vision programs. They really fill the gaps where lots of other programs are unable to serve. And we urge you to really make sure that the upcoming budget doesn't impede all of the great work you're hearing about today. Thank you.
Hi, Kim Thomas with the Children's Network in Solano County. I have testimony I will leave. What I want to speak to at this point, since the time is brief, is just to say that I read the agenda, and the LAO is recommending that First Five be sacrificed in favor of unspecified core programs. What First Five programs do is provide services that keep kids out of your expensive core programs. And I would think that if we lose this funding, and if we lose our ability to intervene early with children and keep them out of harm's way, by the many ways you're hearing today, that you will end up with much bigger expenses in those core programs that cost so much. So I think this is a really unwise path to go down. And I'm also curious about why it is, if we can put something like First Five back on the ballot again, why we can't put other options back on the ballot, such as, oh, I don't know, oil severance tax, and solve the real problem. So that's it. And I will leave the testimony.
Thank you very much for your testimony. Next witness.
Good afternoon. I'm Leticia Alejandres. I'm the Executive Director of the California Family Resource Association. We're a statewide association that represents family resource centers throughout California. We represent over 150 family resource centers that serve millions of families annually, and many are funded through First Five, which we urge you to maintain that funding. These family resource centers provide an array of vital health and human services for families. These services are community-based, family-centered, prevention-oriented, and they're designed to address family issues, health and human services issues early, before crisis, when things become costly. They serve as the safety net in most communities, and these organizations are trusted and efficient, and they leverage every dollar that they get, which makes them a great investment. This diversion would devastate this infrastructure of family resource centers, these community-based programs. Permanent cuts would lead to permanent dismantling of this hub. And these hubs consist of common sense, low-cost, culturally appropriate supports and services to low-income families. We urge you to oppose this diversion. Thank you.
Thank you. Next witness.
Good afternoon, Madam Chair. My name is Katie Villegas, and I'm the Executive Director of the Yolo County Children's Alliance. First Five YOLO does so much more than fund health insurance and health care. In Yolo County, we fund things like foster parent recruitment, food distribution, universal preschool in West Sacramento, and dental care, and even a home visiting program. We've been able at the Yolo County Children's Alliance, and many of the funded programs in Yolo County have been able to match funds. We've brought in matching federal funds and local funds and foundation funding, and it's been really helpful in Yolo County. It's been an institution in Yolo County. Our funded partners want to be part of the solution, so I urge you to work with Sherry Novick from First Five Association, and in keeping with the governor's proposal, give cities and counties more local control. First Five county commissions demonstrate the success in defining local needs and funding programs locally that need to be addressed. Thank you.
Thank you. Next witness.
Good afternoon. My name is Tico Zendejas, and I work with RISE Incorporated. It's Rural Innovation for Social Economics, and I'm here on behalf of YOLO First Five. Wanting to talk a little bit about the programs that YOLO First Five funds in rural Yolo County, which is Esparto, Madison, and the Capay Valley. We have the Universal Preschool Program that funds 28 kids on a daily basis, has 54 families enrolled. And I don't know if you guys are familiar with Esparto and Madison, but it's a very, very small community, but those numbers are very large for our community. We build a place, a safe place for parents to come with their child that in the community has about 60% that are Spanish speaking. So they come to this center and are engaged in learning in the English language for the very first time. They're building social skills, they're building self-esteem, and they're working hands-on with their parents that are able to take this home and reinforce the skills that they learn at home. So we really encourage you to come up with other solutions, because this would kill our community of rural Western Yolo County, and rural families matter too. Thank you very much for your time.
Thank you for your testimony. Next witness.
Good afternoon, Assembly members. My name is Francisco Rocco. I'm a developmental psychologist, work with multidisciplinary assessment clinic at San Francisco General Pediatrics. It's fully funded through First Five, and we've made a huge difference on 500 families over the last 2 years. We see kids with developmental disabilities, learning problems, they have been traumatized, or have multiple medical conditions. My area of research is developmental neurobiology, and there's a wealth of information about the changes that happen in the brain in the first 5 years. It's most susceptible to intervention and also most vulnerable to the damages of a not well-cared life. I heard the state of the state by our Governor Brown, and he says the promise of California. So saving money right now will kick down the can, and it will be multiplied by many more billions down the line in teenage pregnancy, unrealized revenue from taxes, criminal justice system. So our state depends on you folks, and the kids are the promise of our state, and it's really backed by science. Please don't cut funds for 0 to 5.
Thank you very much for your testimony.
Thank you. Dawn Kepke with McHugh and Associates on behalf of the Child Abuse Prevention Center, who is concerned and opposed to this redirection and cuts. The Child Abuse Prevention Center works with child abuse prevention councils around the state, as well as other community-based organizations, to work towards prevention of child abuse and neglect. We know how to prevent child abuse, and the center, in working with our colleagues, is able to do that work for about $1,200 per child. Whereas a national study conducted by the Prevent Child Abuse America found that if a child enters the system because we weren't able to prevent that abuse and neglect, the costs are $100,000 plus per child. Furthermore, a national study was also conducted to identify and understand the impacts financially associated with child abuse and neglect, and the findings were staggering at over $104 billion nationally, resulting largely from impacts on corrections, special education, health impacts from child abuse alone.
10 seconds.
So for this reason, we really urge you to reconsider this, and we are opposed. Thank you.
Thank you very much. Next witness.
Good afternoon. My name is Nancy Marshall, and I'm a manager with Sacramento County's Child Protective Services. My expertise is in early intervention and prevention programs. I'm here to speak on behalf of Sacramento County's First Five Commission and the safety net services they provide to the children in our county, asking you not to divert those revenues away from the children. Speaking for Sacramento's Child Protective Service, and likely my counterparts in the rest of the state, the last 2 years have seen vital services cut, staff layoffs, and budgets slashed. Prop 10 funds, administered rigorously by Sacramento's First Five Commission, have funded critical prevention and intervention programs aimed at keeping children and their families out of the child welfare system at a substantial savings to the taxpayers and the state. I would echo the previous speaker in talking about what we know works and what the difference in cost is.
10 seconds.
Okay. I can attest for several vital services that would have ceased to exist in Sacramento County had we not had First Five to fund those programs. Earlier, the gentleman said, pay me now or pay me later. I'll just ask you, do the math. Prop 10 funded prevention programs work and save the state and the taxpayers money in the long run. Thank you.
Thank you.
Good afternoon. My name is Noemi Lovelace, and I represent the Castro Plaza Family Resource Center in Monterey County within the North Monterey County Unified School District. For over 10 years, First Five Monterey County has partnered with the community to ensure young children get the best start of life. At the Family Resource Center, we offer services as a hub to families who could just walk and receive our services. They connect those most in need to quality early learning programs. We support effective First Five fundings, support effective local prevention and early intervention programs within communities. It helps keep local organizations do business in a way that results in lasting positive changes, such as family resource centers. Please, we urge you to keep resources and decisions at the local level. With First Five funding, elimination could also have impact on school readiness and having children prepared for kindergarten. This proposal could effectively eliminate local safety net programs and direct services to children 0 to 5. I urge you once again, reject this proposal. In a minute, you'll hear families that actually have had impacted from this positive programs that we've been able to offer in Monterey County. Thank you.
Thank you. Next witness.
I'm Laura Garcia. I'm a parent as teacher instructor, and I've served 32 families doing home visits, playgroups, and parenting classes. And I'm just going to translate from some of the families that are in my program.
Buenas tardes, mi nombre es Luis Ramírez, padre de 3 hijos, de un niño de 1 año 8 meses, 2 niños de 4 años, y estamos aquí para que no nos quiten los fondos de los primeros 5, para que nos sigan apoyando con los programas que tienen, porque nos han ayudado mucho para el crecimiento de nuestros niños. Por favor, no nos quiten los fondos de los primeros 5. Gracias.
Please don't take the funding from First Five. He has 3 children.
Buenas tardes, mi nombre es María Díaz, soy madre de 2 niños, de una niña de 24 meses, un niño de 36 meses. Me gustaría que no quitaran los fondos de los primeros 5 de California. Venimos de Castroville, representando a los demás padres que no pudieron estar aquí. Necesitamos esa ayuda, queremos ser mejores padres y gracias.
My name is Maria Diaz, and I have 2 kids, 24 months old and 30 months old. And I'm representing all the families from Castroville. And please don't take the funding from First Five. And we just want to learn and to be better parents.
Buenas tardes, mi nombre es Natalia Hernández. Tengo 2 niños, uno de 3 años. La bebé de 9 meses, que la dejé por primera vez porque quiero, por favor, que no quiten los fondos del programa, los primeros 5. Gracias.
My name is Natalia, and I have a little girl, 9 months old, and I just left her today for the first time because I'm here, because I don't want you to take the funding from First Five. Thank you.
Thank you, and she'll be all right. She'll be there when you get home. Mr. Manning.
Thank you, Madam Chair. Quisiera decir gracias a los testigos del Condado de Monterey. Gracias por su presencia, por su testimonio y por su apoyo de este programa muy importante, por sus familias, pero por toda la comunidad. Gracias por su viaje y por su testimonio. Gracias. Thank you.
Go ahead, Mr. Manning. Next witness, please.
Madam Chair and members, I'm Sharon Scott Dow with Advancement Project, and we would just like to register our strong opposition both on the state level and at the local commission level about this funding. Thanks so much.
Thank you. Next witness.
Madam Chair and Assembly members, my name is Gary Rotto. I'm the Director of Health Policy with the Council of Community Clinics. We're comprised of 16 private nonprofit health organizations in San Diego, Imperial, and Riverside counties, and concerned about the proposal and especially about how it could potentially be implemented when staff mentioned about potential of canceling contracts. And that being because we have a contract with our local First Five for what's called the Oral Health Initiative for providing dental services to children up to 5 years of age. Overall, our consortium has 650,000 patients. A portion of that are children in that age range, and we provide services throughout the region, especially with Fallbrook Family Health Center in Assemblymember Jeffrey's district. The way that the contract is written with First Five is that it's a 1-year contract with 4 one-year options, and that's just consistent with what County of San Diego policy and therefore First Five policy in San Diego is to hold all, whether it's us or other service providers, accountable on a year-by-year basis. And so we'd be very concerned about how those option years would be able to continue, even though they're in contract, whether that's considered encumbered or not. Thank you.
Thank you very much. Next witness.
Good afternoon. I'm Carol Baker from First Five LA, and I just actually wanted to echo what the gentleman before me just said, that this proposal really puts all of our efforts, all of our programs at risk, everything that's not currently contracted in the current contract year, and it's simply because it's a huge diversion of our voter-approved funds. It is Prop 1D on steroids for us. We ask that you therefore try and mitigate the impact to local commissions that are providing the direct services that you just heard about from families and from providers who are supported by local commissions. Thank you very much.
Thank you very much. Are any final questions from committee members or any final statements from Finance or Ms. Novick, LAO? Thank to so many of you for traveling up today to participate in the hearing. And it's the committee's recommendation to hold this item open. Thank you very much. We'll move on to item 4260, Department of Health Care Services, Medi-Cal.
Consumers first, my friend. Trust us on this.
No, I know.
I just hang out with that.
Mr. Chesbro, you think it's time for a stretch break?
I think it's a great idea.
We're going to take 30 seconds. I want to encourage everyone in the committee to stand and stretch. As we're talking about health services, we're going to practice what we preach.
Yeah.
Which I don't usually say.
I talked on the phone a couple weeks
Well,
ago
you know,
with the Department of Finance.
13
That's going to be
takes 13.
Oh, great. Yeah.
Yes.
I will.
And
So that within 30 days
Lots
we'll
of cards in my office.
Yeah.
Yeah, that's what I'm going to say.
or if they're lucky, they'll wind up in the emergency room for a while and be admitted to intensive care, stabilized, and then put back out on the street for another week until it happens again.
Oh, hi.
Well,
Because they will be homeless. Because they will spend their money. They will spend the rent money on the car.
Well, this is designed to take care of 90% of the Medi-Cal patients, but that's 700,000 that they've left out.
Well, more than that. As you know, 20% of the people have 80% of the care. So I'm curious, are you one of the folks affected? Are you one of the folks affected by the limit on doctor visits? Yes. Would you like to go first? We're happy to go. We do this all the time. We're happy to have you go first. Okay?
Yes, I'm with the organization Dog Fight, which is like disability organization group for initiating total equality.
Okay.
I don't have a lot to say, but
Okay. Jim, a minute will be terrific from somebody who really affects.
It's right on the same floor, Barnaby and Barnaby.
Oh, okay. I don't always go around the corner.
No, you're going down the other way to the women's room. The men's room is not outside.
Men's room is on the other side.
And Brian Augustus is in here.
Yes, he is.
Brian's an old friend.
Bill and I've known each other a week or two.
Well, Brian grew up with my son.
So Don Molds was the first person I ever said to, oh, I know your mother. I was just like, oh, God, I'm so old.
Betty.
Yeah.
John and Betty.
Yes.
They were a couple long before there was even a played hooky with both of them.
So one of our best lobbies.
Thank you. We'll go ahead and get started with, well, before we get started, let me just attempt to organize and consolidate, if you will, the 16 issues before us. How are you? Under Medi-Cal. It's my suggestion that that in your presentation, after we review the reduction chart on page 18, that we group items 1 and 2. Fair enough? And so this will be important for witnesses in the public who are going to provide public comment. Please know that we're going to group issue items 1 and 2, the hard cap, the 10 visits to physicians, and the 6 prescription outpatient drugs. We'll take public comment after this presentation of the second issue. We're then going to group issue items 3 through 6. So we'll take public comment after issue item 6. We'll hear issue items 7, 8, 9, and 10 individually. 7, 8, 9. We're grouping 10 through 12. Then we're going to group issue items 10, 11, and 12. We will then group issue items 13 and 14. And we will hear 15, 16, and 17 individually. Okay? So we'll start with the overview and hear issues items 1 and 2.
Madam Chair, members of the committee, Toby Douglas, Director of Department of Healthcare Services. Thank you for having me here. The Department of Healthcare Services in its budget has reductions accumulating up to $1.7 billion general fund. These are reductions that will have significant impacts on our beneficiaries, in many cases on the most vulnerable beneficiaries. We don't come here without acknowledging the impacts, but given our budget situation, these are the proposals that we're coming forward with. They are also due to the limited ability to reduce expenditures in the Medi-Cal program given federal rules on eligibility. These reductions are primarily in the area of benefit reductions and cost sharing. So the first item that we are proposing is a hard cap on physician and clinic visits. Under the Medicaid program, there are mandatory types of benefits, including physician office visits. Within these different benefits, there are the opportunity for states to have utilization controls. And what we're proposing is to actually have a hard control, a hard cap on visits that beneficiaries, in this case only adults, would be able to have 10 visits in a year. There are other states that have hard caps on other types of services. For example, some states have hard caps on prescription drugs. Some states, including Alabama, has a hard cap on inpatient services. So there are states that have had the ability to make this hard cap. There are no states that we know of that has an actual hard cap, meaning that they can't, individual can't receive more services for physician and clinic visits. There are some states that have utilization controls where after 10 or a certain number of visits, they have individuals prior authorized before they receive more services. But we're proposing actually cut off at 10 visits. This would require state plan amendment under federal rules. The second item is a hard cap on prescription services of 6 prescriptions per month. Right now, we have what's called a soft cap, where individuals can have 6 prescriptions in a month, and then after that 6 prescription limit, they have to receive authorization for additional prescriptions. We would be changing that to actually, again, to cap it at 6. There would be exceptions for life-saving drugs above that limit, as well as such as mental health services, AIDS drugs. There would be other exceptions. But for other individuals, adults only, again, there would be a hard cap. So any questions on these two proposals?
Mr. Chesborough?
Well, I have a question that is on these two proposals taken together with some that are yet to come, sort of an overarching question. Okay. Has the department had a physician or clinician do an analysis to determine what increase in morbidity would occur as a result of hard caps and also co-payments and other limitations that would deter people from seeking help?
No, the department has not done that type of analysis. Given the time frames on this budget, we have not been able to do that. The budget does, as I said, we as a department will acknowledge this is going to have impacts. Those above these limits are the most chronically ill, acute individuals. In most cases, there are some instances where it's overutilization, but there is an expectation there will be impacts. How it plays out, we don't know, and therefore those assumptions are not in the budget.
Okay. Monty.
Thank you, Mr. Douglas, all members of the panel. I know we haven't heard from some of you yet, and I know there's a lot of people here to testify. In arriving at this proposed budget savings by I'll call it the rationing or the hard cap on 10 visits and also on the prescription drugs, it seems that this is a clear example where the state is trying to artificially create certain prescriptions for the number of visits and the number of prescriptions that may not address the needs of a particular patient. Has there been any consideration to achieving the same savings but allowing treating physicians and medical care providers to determine the allocation? In other words, one patient may need 17 visits a year. A relatively healthy patient may only acquire 3 visits a year, and you could achieve the same savings without compromising the need of that higher need patient who may need 17 visits. You understand the formulation that I'm working towards? Is there some other way to achieve these savings but give that decision making to treating physicians and healthcare providers as opposed to a artificial limit on each recipient?
Well, this gets to there's just the really, really tough choices and the need to drive to fiscal savings. I would say that our push and our move to mandatory enrollment of our persons with disabilities in managed care with the support of the legislature last year really drives forward the policy goals that you're outlining, where we're providing organized delivery systems the ability to better coordinate and manage the care and provide the right amounts of care. Now, this proposal is dealing with the factor that we only have certain sufficient dollars in the system, and that we have to go even farther than managing and looking at where under federal rules we have the flexibility to actually drive down expenditures. And it will have, there are individuals that are above 10 who are going to need those services, and federal rules we found in other states have said that if you're covering the majority of the need of the population, and in this court, it was in the Circuit Court, it was 88%, then you're covering sufficient needs of the population. So we set the limit at 10 to cover 90%. But if we had sufficient dollars, we'd do exactly what you were saying, and we drive our managed care plans to continue to drive down utilization, taking in the needs of those with the highest need and lowest need.
Thank you. And then just with respect to the prescription limit of 6 prescriptions, is there a limit on how many days each prescription can be filled for? In other words, if you need a prescription for drug A and you're going to need it year-round, can you get one prescription that provides for 12 months, or is it a 30-day limit? Do you know how that rationing would happen?
We didn't change the limits on prescription, or the length, and most are for 100 days.
Okay, that's helpful. Thank you. Thank you, Madam Chair.
Finance.
John Wunderlich with the Department of Finance, and just to reiterate Mr. Douglas's comments at the beginning, that we recognize there are impacts from these proposals, and what's driving these is the need to achieve savings where, in an environment where there are, quite a few limitations within the Medi-Cal program.
In keeping with that, have you factored in potential increased costs to ER room visits?
The budget savings projected do not account for potential shifts to other services.
LAO.
Thank you, Madam Chair. Meredith Worden with the Legislative Analyst's Office. Again, given the state's fiscal situation, we recommend you consider these proposals. We note that they were heard last May and rejected by the legislature, and recognize also that these will have significant impacts on program beneficiaries. With regard to the utilization limits or hard cap proposals we just heard, we would note that with a lot of these proposals that the savings may be overstated. As we have heard, some of the cost shifts have not been accounted for. And in addition, that they may disproportionately affect some really fragile beneficiaries. With regard to the hard cap on the physician visits and clinic visits, we recommend you consider an alternative approach, such that maybe providing for some exemptions for certain conditions and beneficiaries. Granted, it will likely achieve less in savings, mitigate some of the impacts on the beneficiaries, and in some cases could be more burdensome for the department to administer. With regard to the the hard caps on the 6 prescriptions, we recommend that you deny the governor's proposal. We believe this is a core benefit and could significantly impact outcomes of beneficiaries.
Any questions of committee members?
Just had one quick question. Thank you, Madam Chair. I just had a question about was the number 10, on the cap determined really based upon cost savings, or was there some science, used to determine what the hard cap became at 10? landed at 10?
Good question. As I noted, and there's been Medicaid cases in other states where other states have put hard caps on other services. And in South Carolina, they had put a hard cap on their inpatient services that covered about 88% of the population. Third Circuit Court ruled that that was sufficient to cover the needs of the population. So we looked at what was the level that would cover 90%, and that was 10 visits.
Mr. Chesbrough.
I'm going to rephrase my earlier question a little bit for the LAO, because increase in morbidity is sort of an abstract term. Are you aware of any research that's been done statistically with regards to these types of caps that exist in other states, and what kind of a death rate they result in? Maybe that's a little clearer term.
Thank you, Mr. Chesbrough. I am not currently aware. We can certainly work with staff to see what might be out there with regard to studies and literature, but
Thank you.
I don't know.
I have a question with regard to the prescription drug cap. You say that life-saving drugs will be exempted. How are you going to define life-saving drugs? Because I guess I have a concern about drugs that have a major impact on a patient's health and well-being, and perhaps helping them maintain, chronic conditions. And so, how are you defining life-saving? Will that be defined in trailer bill language? How are you going to manage that?
Vanessa Baird, Department of Healthcare Services. As Mr. Douglas mentioned earlier, we already do have some exemptions to the current soft cap of 6 prescriptions for things such as treatment of HIV, AIDS, and cancer. When we implement the proposal for this, this proposal would include life-saving drugs. We have looked at other states. The state of Tennessee has a list of exempt drug categories that we believe is a good starting point. So these are drugs that treat Parkinson's disease, antivirals, clotting factors, diabetes, dialysis medications, immunosuppressives. There's a long list. But we would also take a look, and this would be our medical consultants, our doctors in our department. For us, the definition of life-saving is drugs that are needed to cure or mitigate things that are happening that without treatment would lead to premature death. And so we will be looking at what drugs are necessary to add on to that list. So the Tennessee list is not considered to be exhaustive by any.
So it'll basically be like another formulary that I guess would be updated as new drugs come online and are available to treat chronic conditions?
And the proposed trailer bill language is not going to specify what exactly those drugs would be, simply
the
because
conditions.
Things do change rapidly,
Okay.
and we want to be able to respond rapidly as necessary.
Any other questions or comments from the committee? I see a long line of eager witnesses. So I would just remind you and strongly encourage you to not repeat statements made by a previous witness. It's really okay to say your name, the organization you're representing, and your position you're taking on this budget proposal. Everyone will be limited to a minute, and I'll be using the timer. Thank you. First witness.
Okay. My name is Lucille McGeehan, and I'm with Dogfight, which stands for Disability Organizing Group for Initiating Total Equality. With only 10 visits to the doctor, the people that need to visit the doctor regularly, such as for kidney dialysis, what are they to do? I need to see my doctor more than 10 visits. I'm 5150 and my medication depends on that. I take shots, so I need to see the doctor for my Haldol shots. What am I to do? Without the dental and the vision, what are we to do? It's barbaric. You're hitting people who live at the poverty level or near poverty level. We urge you to oppose this. Thank you.
Thank you very much for your testimony. Next witness.
My name is Janet Kyriakopoulos, and I'm a diabetic, and I'll be getting into kidney dialysis, and I take more than about 10 different medicines, and God knows how much more. And I won't be able to afford medicines. I guess I'm going to get my death sentence because I really don't know what's going to happen. Thank you.
Thank you. Thank you for coming to share that. Next witness.
Beth Capel, on behalf of Health Access California, also opposed. These cuts will result in deaths. People will be cut off kidney dialysis after 3 months. They will be cut off cancer treatment within weeks. They will not have care for sufficient care for heart attack. Unlike Arizona, that we will not simply eliminate some organ transplants. We will eliminate all organ transplants. People with HIV will not get the care they need. The list goes on and on. Medically fragile individuals does not fully capture the death rate that will ensue from these cuts, nor does it capture the increase in preventable and avoidable hospitalizations in emergency care that will eat any savings. And we would add that to the extent that there's this cut applies to both fee-for-service and managed care. To the extent that we have overutilization in managed care, there are better solutions than simply cutting people off and letting them die. Thank you.
Thank you, Ms. Capel. Really quickly, I'm sorry. Something Ms. Capel said reminded me of a question I had earlier in terms of the concern around overutilization. That's an issue that's come up in the Medi-Cal program for the many years I've worked in this area. Are there any recent studies that you can point to that talks about your concern around overutilization in Medi-Cal, either on the fee-for-service or managed care?
Well, again, Madam Chair, this proposal isn't focused on asserting that there's overutilization. It really is about the finite resources that we have available. We really, from an overutilization perspective, it really is our proposal last year of moving persons with disabilities into managed care for better coordination and outcome. We don't have studies to determine the true percent. We do believe that managed care, our movement to managed care, is going to result in more than 10% savings. And that's budgeted as well in the budget, and this is another approach.
If I might, Madam Chair, it is our belief that this proposal violates both the spirit, if not the letter, of the 1115 waiver that we were granted, which assumed that people in managed care would be getting medically necessary care as those of the rest of us in managed care do. We believe it also violates the spirit, if not the letter, of the earlier 1115 waiver for mandatory managed care for moms and kids. So we think it's legally dubious as well as cruel.
Thank you. Next witness.
Vanessa Hino with Western Center on Law and Poverty, here in opposition to both of the caps on prescriptions and 10 doctor/clinic visits per year. In terms of the caps, what is really most troubling about this is the fact that there's no exemption for people with serious or chronic health conditions. So when you start to talk about people like Janet who are on dialysis, or people with HIV/AIDS, or people who are going through chemotherapy, which my colleagues are going to address later, this is ultimately a death sentence for them. So, I mean, really, when we start to talk about, well, 90% of people aren't going to be affected by this. What about that 10%? What about the sickest 10% that are affected by it? The other problem here is that in terms of the prescription drug caps, the exemptions would be for life-saving drugs. I'm holding the trailer bill language. There's no determination on what a life-saving drug is. With that, we oppose this.
Good afternoon, Madam Chair and members. I'm Bill Barnaby here representing DaVita Dialysis and the California Medical Transportation Association that transports dialysis patients primarily. The typical dialysis patient needs medically necessary 3 visits a week, so they would have 13 in a typical month. This would limit them to 10. So you don't make kidney failure a capital offense, a death penalty, please. We urge your opposition. Thank you.
Thank you, Madam Chair, members of the committee. Carolyn Janot with the California Medical Association, also opposed to both proposals. The proposals for the caps, both on physician and clinic visits as well as prescriptions annually, will have deleterious impacts both on access as far as the network is concerned, and then on the back end of the system too, and as much as enrollee behavior is concerned. For access, we already have a huge shortage of doctors willing to take Medi-Cal patients. So this, coupled with the proposed rate decrease, the co-pays that will be brought up later, all of those things just serve as more disincentives for physicians to participate in the system. And what ends up happening then, and recent studies have shown this, is that Medicaid enrollees are at least twice as likely to use emergency rooms for care than the regular population. And that produces huge costs at the other end of the system. Just one more comment, too, on the numbers that Ms. Kahina mentioned earlier. When the department mentions that the 10-visit cap was derived from trying to find a number that would cover 90% of current enrollees, I think the committee's backgrounder is very telling because it does mention that the estimate is 3.3 million visits in a year, and this proposal will remove 30 to 40% of those. So that 10% that we're dealing with, it needs those services, and we think that that's a very important number to look at and shows how big this problem is.
Thank you. Next witness.
Madam Chair, members of the committee, I'm Gary Passmore with the Congress of California Seniors, and to help you save time, I want to talk about both the caps and the copays. We'd like to connect the dots for you a little bit. First of all, you've heard about the notion that a relatively small number or percentage of patients eat up an enormous share of healthcare costs. I'm here guilty as accused. It is our seniors that eat up those costs, and we're very concerned about these recommendations. Second point, doctors and prescription drugs have been shown over the last several decades to control illness, to control healthcare costs, and we're opening ourselves up for higher costs shifted to other places within the healthcare system. The last point I want to make is a little stretch, but it's an important one. This state considered a healthcare reform proposal several years ago, and the former administration made a very convincing case that the low rates for Medi-Cal providers and the restrictions on providing care under Medi-Cal shifted healthcare costs to private consumers of healthcare insurance. You're looking at the reasons for why all the insurance policies are going up in the rates that they're charging, and I'm not making any apologies for them, but everything fits together. Thanks.
Thank you.
Randy Hicks, California's Disability Rights. My only question is, how will I know? I take 4 prescription drugs, 4 of them. How will I know when I've reached my limit? How will I know when I've reached my limit on visits? How will I know? How much is it going to cost for you guys to send out a letter from DSS, saying, you know what, you've reached your limit. You now can no longer have any more visits. What if you don't get that letter? You go to the hospital, or you go get your prescription drugs, and all of a sudden, you can't have any more prescription drugs because you've reached your limit. You either lost your letter in the mail, or they don't have the right address. This is going to cost more money than it saves because you're now setting them up another system that says take survey of how many prescription drugs you're taking, how many visits do you have. All of a sudden, you're not going to be able to keep up. It's going to cost more money than it saves.
Thank you, sir. Next, Mr. Chesborough.
May I just ask, raises a really important question of who's going to keep track of and how are they going to know? Is the provider liable if somebody comes on and unless they have a database that we provide them with, how are they going to know, and are they going to wind up not being reimbursed because they saw somebody who was over the limit?
We have had some limits enacted in the past for certain therapies and other services for lab where we set up through our fiscal intermediary, our claims processing system, what's called a reservation system that lays out how many visits or services have been utilized. So what we would envision if this was enacted is that physicians would be able to access a similar type system to see how many visits a beneficiary had utilized and know if they've hit the limit and whether it needs to be funded out of pocket by the beneficiary or as charity care.
Is the cost and the time involved in that factored into the schedule and the projected savings?
I believe it is not. I would not be close to the savings of this proposal, but there would be costs related to it.
Thank you.
Mr. Monning.
Thank you, Madam Chair. I'm sorry to break the flow of the testimony. I just wanted to follow up on a couple of witnesses asked about the question of kidney dialysis. Do you have a response to that? Does a dialysis treatment count as one visit?
Unfortunately, the answer is it does.
So 3 dialysis treatments a week, you're going to use your quota in 3.5 weeks?
That's correct.
Well, I would urge the department to consider, as you've exempted some life-threatening drugs available for life-sustaining drug support, that you do the same with certain required life-sustaining medical visits. Thank you.
If I could just have the witness representing CMA, you've got a response to Mr. Chesbro's question, so if she could just be allowed to respond.
Thank you, Madam Chair. Thank you so much, Senator Chesbro, too, for asking the question. In as much as the administrative complications are concerned, physicians are very concerned about how to deal with, the 10-visit limit. You get into a problem, too, with scheduling. Right now, there isn't a visit limit, so there's an education, that's going to have to happen with providers throughout the state that are still going to agree to take Medi-Cal as to how to use that. And then also, if you set a patient for an appointment, maybe that appointment is in a week or two. What's happened in the intervening weeks? Are we going to have extra staff be hired in physician offices and clinics just to be able to handle that administrative burden? And once again, that's another disincentive to participate in the system at all. Thank you.
Thank you. Thanks for your patience, witness.
Michelle Rousey. I came up here for Krill Community Resources in Hayward. I've been seeing a doctor who takes Medi-Cal, who took me after I left Kaiser, who took me only after 6 months of not being able to get a doctor. I take more than 12 medications in a month, and being able to get those medications is very important to me, and most of them are life savings. I have chronic pain and multiple ailments, and being able to get into my doctor's I see him every month, but sometimes I need to see him every 2 weeks, and that keeps me out of the hospital. I used to go in the hospital 2 or 3 times a month, and I haven't been in the hospital in a couple of years now because my doctor sees me on a regular basis. That keeps me out of the hospital, costing the state less. You cut my visits, it's going to cost the state more because I will end up in the hospital because I'm not seeing my doctor enough. Don't cut our visits. Don't cut our prescriptions. We can't afford any more cuts. We can't afford them. You're cutting us every which way. We can't afford any more cuts. Stop cutting us. Thank you.
Thank you, Michelle. Next witness, please.
My name is Carmen Rivera Hendrickson. I see the doctor 5 times a month, and that's 5 different doctors. My heart, my respiratory, my spinal, which is my neurologist, my counselor, and my mental doctor, which gives me my prescriptions. If I don't see him, I cannot function like I am here today. I am condemned to a bed. I don't want to be back in a bed. I just suffered a stroke, and this is my 3rd stroke. I've had 3 heart attacks. I've been dead 3 times. I've had hard enough time. I live on 48 prescriptions a month. If I don't have those prescriptions, I can't breathe, my heart won't function, I can't do anything. And I don't want to be a vegetable in bed. I flatly refuse to go to a nursing home, so I do not want to be out in the street. So please do not cut my doctor visits. It's the only way I can keep normal, and there's a lot of people that count on that.
Carmen, of your 48 prescriptions a month, how many would you say are, quote, life-saving?
Pretty much all of them. Because if not, I would not be mentally functioning because of everything I've gone through in my life.
Thank you very much for your testimony. Next witness.
Madam Chairman and members, Nathan Mansky representing Adventist Health that operates 13 hospitals and the largest system of rural clinics in California, and also Loma Linda University Medical Center. We're here on 2 issues, or I have 2 points rather, on the issue of capping physician visits and clinic visits. And I think Mr. Monning made the first one for me very well, and that is the arbitrary nature, or as we would call it kind of the one-size-fits-all on the number of 10. And we recognize that the administration and the legislature have a very difficult job here. The second point of opposition, and it's well recorded on this item, and a number of others in your agenda by staff, and that's the issue of cost shifting. We think without question there will be cost shifts to emergency rooms and hospitals notwithstanding, and this is the item you'll talk about later, but the mandatory copays, I think, to attempt to discourage that. Don't want to get ahead of your agenda, but we don't think those things will work. Thank you very much.
Thank you. Next witness.
Good afternoon. My name is Yvonne Andes, and I am still the mother of a 35-year-old schizophrenic, autistic, and developmentally disabled young man. Under the current Medi-Cal budget, Jack's schizophrenia is under control. Currently, he takes a total of 6 different prescriptions to control his schizophrenia per month, and he sees his doctor once a month to monitor kidney and liver function because the drugs are so toxic. Jack functions right now just like a regular guy. You wouldn't know that he was sick. He works in the community. He participates in all sorts of special needs activities, and he does remarkably well. He was just awarded by North Bay Regional Center the most improved citizen in Sonoma County. And the award ceremony is going to be at his church on February 20th, in case anyone is interested. But this was not the case several years ago. Jack was admitted several times to the hospital. He was suicidal. He tried to harm his sister. He tried to kill her on many different occasions, and he threatened others. I understand that the governor, that we all need to have a balanced budget. It's imperative that we achieve this goal. I also recognize the extraordinary waste and the abuse of the monies that have been made available to this state over the years without financial oversight in place to staunch the flow of corruption and abuse. This is not the fault of my son or thousands like him who rely on these programs to live. I would just ask that you don't make my son or other people like him a casualty of a broken government. Thank you.
Thank you.
Good afternoon, Madam Chair and members. Peter Gamby on behalf of the Association of California Healthcare Districts. We are strongly opposed to this proposal, both of these proposals, for reasons very eloquently articulated by several of those who have come before me, and because we feel it is overly rigid, short-sighted, will lead to unnecessary emergency room and inpatient admissions, and jeopardize people's health. We urge you to reject it.
Thank you. Next witness.
Chair and members, Kathy Mossberg representing the San Francisco AIDS Foundation, one of the organizations that works with HIV and AIDS patients and clients, and one of the chronic conditions that have been discussed here. We would agree with the comments made by Chair and members about looking at an exemption for those with chronic diseases. With that said, we are opposed to both of these cuts. If we are to go forward, though, to look at an exemption in both these things, for that reason, would be helpful. In addition to that, I mean, our folks have looked at this. The numbers do, to some degree, bear out that you're looking at about 10% of our population that our folks serve that are going to be hit by this cut. But it's the folks with the hardest hit, that have been hardest hit with the disease and are hardest hit and have the most chronic conditions. Those folks, if they're cut off for services, they will end up in the ER. I know that's been highlighted here, but in addition to what's not been highlighted, is what you guys are going to talk about on page 26, is that we're looking at copays in the ER as well. So folks go there, they get another copay. So this just keeps going and going. In addition to the sort of something that Mr. Douglas has mentioned on the relationship to managed care, this is what we're doing. We are managing care. We are having people come in for visits. We are having them seek care there, not go to the emergency room. That isn't managing care, whether you talk about it in a fee-for-service environment or a managed care environment. So we believe this goes against everything that was done, as Ms. Capel had said, in the 1115 waiver to that degree. Thank you very much.
Thank you. Next witness.
Good afternoon. My name is Brad Engel. I'm the operations manager of the Bay Area Coalition of Concerned Medical Professionals, an all-volunteer private membership association of professionals and other concerned citizens who have fought for health care for low-income working people since 1976. We urge the committee and the state to not adopt the cuts in Medi-Cal and Healthy Families program because it would be completely detrimental to low-income working people and the poor. Our medical director, Dr. James Eichels, a family practitioner, has asked me to pass on a message to you. I speak for many in my profession when I say that I admire your determination to turn around years of irresponsible government financing practices in your attempt to balance the state budget. It should go without saying that the government needs to apply the same principles financing itself that families and businesses who survive consistently apply to themselves. Figure out your highest priority, decrease spending, and set aside the money needed to pay for it, including whatever debt has been accrued. CCMP has seen that the state has not done this, and instead, for decades, the state has authorized corporate tax breaks that have resulted in lost money for vital health programs.
10 seconds.
We in the medical profession are weary and wary of the same old approach: slash funding for the government-funded insurances. Preventive care saves lives. If you want to save healthcare dollars, you need to look at where it's being spent. If you search your databases, you'll see that 2 to 5% of the patients are costing you 40 to 50% of the dollars. And if you assign caseworkers, healthcare coaches, and a small number of government-employed primary care physicians to these hotspots, you would make a huge dent in expenses you need within the calendar year. Hospitals, radiology facilities, and other high-cost providers of health care may lobby against this, but as health care dollars run out, we won't have the money to pay this. We might as well cut down their business the right way by getting everyone the primary care they need so they don't run up enormous medical bills with unnecessary hospitalizations.
Time.
We ask you to not fund the corporations at the expense of the poor. Thank you.
Thank you very much.
Madam Chairman and members of this Assembly, my name is Loella Wynn, and I live in Alameda. I own an upholstery business there. The 10% cut in the reimbursements for doctors will force many doctors to stop treating the Medi-Cal patients. And rather than cutting Medi-Cal, another solution is called for. Would be like to put policies that put money in the bottom of our communities, ensuring living wages for workers who will spend their money in our local economies. These cuts will cost jobs. If you care about the lives of low-income workers and the poor, then turn away from the governor's plan and abolish the trickle-down programs and act like a true government, looking for the interest for the vast majority of the population instead of catering to a privileged few. Please do not sentence our low income to death by the lack of health care. Thank you.
Thank you very much. Next witness.
Good afternoon, Madam Chair and members. My name is Honor Shaw. I live in San Ramon. I used to work for the Alameda County Healthcare Services Agency at Highland Hospital in Oakland. I'm a commissioner to the San Francisco Presbytery of the PCUSA and serve on the Presbytery Council. Past budget decisions have funneled money away from direct services and into administrative costs and contracting out services to for-profit corporations. The state needs to reverse the situation in which the money spent on health care goes to profits in the insurance industry, inflated costs of prescriptions and health services, and administrative costs such as health industry CEO salaries, which doubled from 2006 to 2007. When faced with a budget problem, you cannot be willing to let the poor suffer and die before you fight for the health care needed.
10 seconds.
Are you going to wait until communicable diseases spread to your wealthy campaign contributors before you fight for the care our state citizens need?
Thank you. Next witness.
Madam Chairwoman and the committee, I'm here to express my opposition to the cuts. My name is Andy Heffernan. I live in Fairfield. I'm a retired teacher. I've taught a lot of kids that were in need and underserved. Imagine living on $800 a month from Social Security. $200 per hospital stay is a quarter of your income. If you're diabetic and have a foot ulcer, Doctors recommend that you come in every 2 days to have the ulcer checked to prevent gangrene that could lead to an amputation. That would use up your 10 doctor visits in less than a month. There is no hope of maintaining a semblance of quality of care for those facing these cuts. In order to qualify for Medicare, you have to have an income below 61% of the federal poverty level. That is really an untenable position. It would result in early and unnecessary death for our most vulnerable citizens.
10 seconds.
Who need more than 10 doctor visits per year and cannot even afford the copay. What does the wielding of the Budget Act send? I'm willing to have my taxes increased to save lives. Thank you.
Thank you.
Thank you to one of my constituents.
Next witness.
Good afternoon. I'm Brandon Tartaglia with Disability Rights California. We oppose these cuts. You can see from many of the folks before me that people with chronic conditions, for them, the caps just won't cut it. The thing is, the need doesn't go away when the coverage goes away. With cost shifts and hospital visits and emergency room visits, we're going to pay for this one way or another. We urge you to reject.
Thank you.
Madam Chair and Members, Terry Thomas on behalf of the California Association of Public Hospitals and Health Systems. Ditto to what everyone has said in terms of the impacts, perhaps unintended consequences. What I do want to say is that this particular proposal seems very puzzling in that it really runs contrary to the work of this legislature for the past several years, where the work is focused on more preventative care and early treatment, finding people medical homes, preparing for reform, and it's counter to best practices of getting people in early for their care. For years, hospitals were criticized for participating in reimbursement policies that seemed to reward inpatient care, perhaps at the expense of beefing up their outpatient services. And over the last several years, public hospitals have tried very, very hard to try to get people into outpatient care, beef up their clinics, and now this policy will just shift them back in the other direction. So we are strongly opposed to this proposal. Thank you.
Thank you.
Madam Chair, members, Judith Riegel with the County Health Executives Association, and also today on behalf of the California State Association of Counties, want to concur with Ms. Thomas's comments, and just to add that we do think that these proposals will result in a cost shift to county health facilities. And on the public health piece, I just wanted to remind folks that the Medi-Cal program is an important player in helping county public health departments prevent the spread of communicable disease, in particular the tuberculosis program, and that the trailer bill language on how the department would decide which drugs to exempt is not clear, and we're not sure whether that would be included. Thank you.
Thank you.
Missy Johnson with the California Retailers Association, representing approximately 35 chain drug pharmacies that operate in communities around California. Numerous studies have been published about the benefits of medication therapy management, both in terms of life savings and cost savings, and we are concerned about what this proposal, along with the mandatory copay proposal, we're concerned what impact that will have on patient medication adherence and compliance. And most specifically, we're concerned about what that means for our chronically ill patients and those who are most medically fragile. This proposal does not provide any flexibility and will likely result in increased state costs because of their hospitalization. Instead, we'd like to urge the committee and the department to consider an alternative that would perhaps cap the number of branded drugs that are dispensed, but allow beneficiaries to receive generic prescriptions that have been deemed medically necessary. Additionally, I'd like to echo comments made by others about the mechanism by which the department will determine which drugs are life-saving and exempt them, as well as the administrative component mentioned by my colleague Ms. Gino at the Medical Association. With that, I'd like to urge you to reject this proposal and please consider the alternative. Thank you.
Thank you. Next witness.
Good afternoon, Madam Chairperson and Assembly members. My name is LaTanya Wolf. I'm a senior at I'm a senior for Hope and Justice at St. Mary's Center. I'm an advocate also for health assets and also for Alameda County Food Bank Coalition. I'm speaking to you to say no, no, no on the caps, on the copay and the doctor's visit. I'm an acute patient. I was hospice stage 4 just a few years ago, less than a year. I had a good year last year, so I only had to have 3 surgeries, and I seen a total of about 4 different specialists, and I had over 14 visits. I'm having kind of a rough day today, but I'm determined to speak and say we come from all different walks of life. We are a very diverse nation. I've contributed and paid into the system all my life. I believed in it. When I came time to use it, it failed me. Please don't fail me now and play with my health by determining how I should live after the struggle I've had to get to where I am and the struggle that I'm having right now standing before you, speaking with you. So I say to you, please, no to the caps and no to the amount of medicines I can have, because who knows, you know? And I'm just saying also that it's very important. I'm speaking now for those who can't speak for themselves. And also remember, we have a lot of people that have contributed so much to our government. All of us were not poverty stricken. So just remember that in your decisions that you're making right now today, that's going to affect whether we live or die.
10 seconds.
Thank you.
Thank you very much.
Good afternoon, Madam Chair and members of the Assembly. Liz Helms, California Chronic Care Coalition. Our coalition represents over 16 million people in the state that have chronic conditions. We understand the problem. We have been part of the solution. We're working on ways to shift out of a crisis care system and into a prevention care system, and we're already showing how we're having extreme cost savings by improving quality and access. What is being done here and being proposed is to unravel all the work that we've done in the last 3 years to improve the lives of the people of this state, and that's unacceptable. And my last comment, I'm very concerned and do not understand why research was not done when these numbers came forward on the 10 limits, the caps and the co-pays without doing a cost shift. I don't understand why that wasn't done, and I'd like to ask that question.
Thank you very much. Next witness.
Hi there, Kristen Hare, California Academy of Family Physicians, as well as the Osteopathic Physicians and Surgeons of California. In the respect for the committee's time, as well as for all the reasons previously stated today, we oppose the caps as well as the co-payments that are proposed today. Thank you.
Thank you. Next witness.
Good afternoon, Chair and members. Allison Ramey on behalf of the California Primary Care Association. Our more than 800 member clinics serve more than 1.5 million Medi-Cal beneficiaries. So all of the proposed reductions to Medi-Cal will have an impact. But of most concern to our members are these hard caps on visits and prescriptions. We've actually gone to our clinicians committee and asked them what this will mean for their patients. And while they acknowledge that there are a number that it will not affect, they are so severely concerned about what it means for those chronically ill and don't quite understand why there are exceptions for life-saving drugs for chronically ill patients, but not exceptions for those visits. Because as we know, visits are needed in order for patients to get the prescriptions that keep them healthy and functioning. So we would urge that this committee consider alternatives, possibly ones related to exempting certain chronic and severe conditions. Thank you.
Thank you. Next witness.
Alicia Sanchez with the American Cancer Society. Cancer is the second leading cause of death in the state, even when you look at people who have access to care, and this would put up another barrier to people accessing the care that they need. I think it's a common misconception that a lot of cancer treatment is inpatient, when in fact increasingly it is now outpatient. As an example, for breast cancer treatment, which of course is the leading cause of cancer in women in the state, radiation is generally not, I mean, you can't speak as a general, in generalities because every cancer is different, but as a general rule, radiation is 5 days a week for multiple weeks, so they would run into the cap very quickly. So I don't think it's hyperbolic to suggest that if these hard caps on doctors' visits go into effect, that people will be dying. So we urge you to reject the cuts. Thank you.
Thank you. Next witness.
Thank you, Madam Chair and members. Carol Risley with the State Council on Developmental Disabilities. I think we all recognize that all Californians must share in solving this problem, so we're not naive that all people will be part of that solution. But these proposals are cost shifts for people who are extremely vulnerable. You've met them in the room. You've talked to their parents. We also urge you to look at the cumulative effect of this. It's not just this cut. It's add them all together, and pretty soon it gets to be a disproportionate impact upon a smaller group of people. We also would suggest to you that these types of cuts reduce people's productivity, take them out of employment when what we're doing is trying to put them in employment and make them tax-paying citizens. Thank you.
Thank you. Next witness.
Hello, my name is Rebecca Gonzalez with the National Association of Social Workers, California chapter. As social workers, we're very concerned with access to health care, and we're especially concerned with our senior community and those with physical and mental disabilities. So we oppose these cuts. Thank you.
Thank you. Next witness.
Hi, Carrie Sanders with the California Pan-Ethnic Health Network and the Having Our Say Coalition. Also opposed to the hard caps on doctor's visits and prescription drugs, as well as the higher copays. As other folks have mentioned, these proposals will have life or death consequences, resulting in increased nursing home use and death, to be blunt. I have some members that we brought up that would like to testify about the impacts.
Thank you.
Good afternoon. My name is Nicole Montojo from the Korean Resource Center in Los Angeles, and we stand in opposition to these cuts and restrictions to Medi-Cal. And we urge you to think about what these proposals will do in the future, not just now, but in 10 or 20 years, and consider what will happen without the protection of Medi-Cal. We could be facing a major health crisis on top of the already burdensome economic crisis. And instead, we urge you to consider other revenue alternatives that could move us toward long-term reform. And I'm here with a senior from our center, and I'll translate after she speaks.
Thank you.
안녕하세요, 국회님. 제 이름은 소청자고 전도센터에서 살고 있습니다. 전 메디칼과 SSI 혜택을 받고 있습니다. 그런데 메디칼 혜택의 축소로 병원 가기가 아주 어려워졌습니다. 의사 보기도 어려워지고요. 그런데 병원 방문을 1년에 10번으로 제한하고 처방약을 6개로 제한한다면 아마 많은 노인네들이 병을 더 크게 유발할 가능성이 많이 있다고 저는 믿고 있습니다. 그리고 이번에 그 발표된 사과만처럼 병원에 갈 때마다 코페이 돈을 낸다고 하면은 많은 사람들이 돈을 내고 병원에 못 갈 거예요. 또 의사도 보기도 어려울 거고. 그렇다면 그 병이 점점 더 악화될 것으로 저는 믿고 있습니다. 그 점에 대해서 좀 참고해 주셨으면 감사하겠습니다.
Hello, my name is Chong Cha Suh. I am 70 years old and living in Los Angeles. I'm a beneficiary of both Medi-Cal and SSI. Seniors need health care, but it is difficult going to the doctors, especially if doctor visits through Medi-Cal get limited to 10 per year and prescription drugs get limited to 6 per month. Many Korean seniors like me have at least one chronic disease and visit the clinic over twice a month and take around 10 prescriptions a month. I myself am struggling to stay healthy, and thus it is hard to survive. If the governor's proposal passes, we will not be able to get proper medical treatment. And moreover, many seniors might rather stay home and grow sicker than have to pay new co-payments that they simply cannot afford. Please think deeply about how this proposal will cause pain for vulnerable seniors like me. Thank you.
Thank you. Next witness.
Madam Chair and members, Rand Martin on behalf of the AIDS Healthcare Foundation. We're opposed to both the hard caps being talked about now for the reasons already stated. I would like to say, with all due respect to my friends at DHCS, who I know are struggling mightily with a really horrible situation with our budget, somebody needs to score what the effect of these hard caps is going to be, and the copays as well. We can talk about what the impact will be, as many people have done, but nobody has sat down and figured out what that cost is actually going to mean to the state of California. And to shift costs in a future budget year is no different a budget trick than making a payment on July 1st instead of June 30th in order to push it into a future budget year. I'm also very skeptical, nervous about the life-saving drugs. I have no doubt that antiretrovirals will be on that list because they are the key to keeping people with AIDS alive. However, there are many other drugs that people take to deal with the comorbidities that go along with AIDS, drugs that actually help a person take the drugs that keep them alive. Are those going to be on the list or not? We don't know. It makes us very nervous, and we're opposed. Thank you.
Thank you. Next witness.
Good afternoon. Alex Graves with the Alzheimer's Association, and on behalf of the 588,000 California families living with the disease, we're opposed to both these proposals. For so many of the reasons that others have already stated, I would just add, Assemblymember Monning asked a question about higher need patients. And people living with Alzheimer's often have 3 to 5 other serious conditions such as diabetes, cancer, heart disease, and also, therefore, in a year will have 3 times as many hospital stays as older people without Alzheimer's. So it's definitely foreseeable that they will be disproportionately impacted by these proposals, and we urge you to not pass them. Thank you.
Thank you very much. Next witness.
Jennifer Snyder on behalf of the National Association of Chain Drugstores. Our pharmacy members are strongly opposed to the hard caps on prescription drugs. Just as Missy Johnson spoke from the Retailers Association, we would encourage the committee to look at other types of cost-saving proposals in the prescription drug program, such as medication therapy management, also utilizing the soft caps that are in place, better utilization of those caps that are already in place that the department uses, and also looking at generic drugs as alternatives for many patients might be helpful, as well as cost-saving measures as an alternative to hard caps, which we believe will actually hit the most at-risk patients. Thank you.
Thank you.
I'm Frank Welty, the Governmental Affairs Director for the California Council of the Blind. I want to make a few quick observations in agreement with those who have already spoken. It's important to realize that the main causes of blindness in the United States are macular degeneration, glaucoma, and diabetic retinopathy, all of which require drugs and medical treatment in order to prevent the progression of these diseases. By imposing these caps on medical visits and prescription, you give patients the Sophie's choice of choosing between protecting their lives and protecting their sight. That's not something you want to do, especially since blindness is most common among seniors. It's very likely that these people who are facing vision loss are going to be facing many other health conditions, which means, again, that they're doubly forced to make choices between saving their lives and saving their sight. This is not right. I would just finally like to add very quickly that, speaking in general of the 17 cuts are we talking about here in Medi-Cal services, that taken together, these are draconian, they are cumulative, that is, they hurt people more than once, not just one time for each of these 17, and they are disproportionately falling on the poor and the elderly. There needs to be a better way to handle this situation.
Thank you very much.
Michael Arnold on behalf of the California Dialysis Council, representing dialysis patients and dialysis providers, starting with the cap on MD and clinic visits. When I first read the proposal, I thought I must be missing something because it would be totally irrational to include dialysis patients. But unfortunately, as Mr. Monning has pointed out, thank you, Assembly Member, dialysis patients are included. So once they hit their 10 visits, then of course they don't have any money. They're going to show up at the ER and present in renal failure, probably have to be admitted, et cetera. Anyway, the costs are going to be astronomical. They'll more than eat up any of the savings that will come as a result of the proposal. Secondly, in terms of the caps on the number of drugs, dialysis patients, like many other patients, have many comorbid conditions. They must have drugs to survive. But importantly, many of the drugs taken by dialysis patients are drugs that are necessary in order to properly metabolize other drugs. So it's going to be very careful. It's going to be very difficult and important that the department, when they're looking at what drugs are providing life-sustaining care, that they carefully analyze not only the drugs that actually provide the care, but also those drugs that allow the patient to properly metabolize. Thank you very much.
Thank you. Next witness.
Hi, good afternoon, Madam Chair and committee members. My name is Christy Hernandez, and I'm here on behalf of Ultimate Health Services. We represent 137,000 patients, many of which have multiple chronic conditions, therefore very dependent on regular doctor visits and prescriptions. And I would like to pose a question and say, first and foremost, that health is not predictable and conditions vary. So how can we dictate the number of visits and prescriptions allowed per patient? Therefore, I ask you to please oppose or reject these proposals. In addition, and not on behalf of Ultimate, but based on my personal experience, my mother is a cancer survivor, and they found a tumor in her liver. Had it not been for the regular doctor visits and the prescriptions, I do not know what the outcome would have been. And therefore, she is now back to 100%, and sometimes it's just a matter of getting over that hump and getting back to that 100%. So thank you so much for your time.
Thank you. Next witness.
Madam Chair and committee members, Gary Rotto, Council of Community Clinics. I mentioned our 16-member organizations. They have 100 sites of care in 3 counties, and I mentioned the 650,000 people that are patients that are now being seen, and that's a 20% increase year to year. That's 100,000 more patients that we're seeing, and a significant number have not only a chronic disease, but they also have a behavioral or mental health issue. So when you put the two together, I mean, you can go through the 10 visits, that hard cap, so quickly, and especially if somebody's new to the clinic world, finally trying to get their conditions under control, trying to get better advice and self-managing, and get the right prescriptions. I mean, it's not logical to have a one-size-fits-all, as you've heard, especially when you're looking at mental health and the work that we're trying to do with the county. Since the county does not have any type of clinic program, we are the safety net. They're really looking to us for mental health and for physical health, and trying to work together on behalf of the community. So please reconsider. Please vote against a hard cap, and rather look at something that's a better alternative and more reasonable. Thank you.
Thank you. Next witness.
Madam Chair and members, Bruce Palmer with the Health Officers Association of California, representing physician, health officers, and local health departments. We'd like to point out to just one instance with the hard cap. 6 prescriptions per month will not work for the treatment of tuberculosis. There are other comorbidities. Many of these patients have diabetes or high blood pressure. Then you also have the problem of multiple drug-resistant TB. And you remember that TB is a highly contagious disease that can be transmitted. It's airborne, transmitted in close quarters, and it can really cause an epidemic of serious proportions. Treating one case of MDR can cost well over $100,000. The right drug regimen, maybe a few $1,000s over a several-month period. So we'd like you to consider that when you close out this policy. Thank you.
Thank you. Next witness.
I'm Beth McGovern with the California Commission on the Status of Women. The proposed caps would deprive people of vital medical services and would particularly impact women. Close to 2/3 of the people who rely on Medi-Cal for those vital healthcare services are women, and they're some of the poorest, most vulnerable women in California. We are opposed to both proposed caps.
Thank you. Any final questions from committee members? Would the department like to do any kind of wrap-up or address any of the issues raised during public comment? I didn't mean that to be funny. I was just...
No, Madam Chair, I don't have other than to acknowledge, I appreciate hearing from members of the audience on these impacts as well.
Thank you. I appreciate that. And we will hold, it's the chair's recommendation that we hold issue items 1 and 2 open. We'll move on to the next grouping of issues. We're going to group all of the copay-oriented issues, issues 3, 4, 5, and 6, dealing with copays for MD and clinic visits, pharmacy, hospital services, dental services.
Currently, the Department of Healthcare Services has a $1 voluntary copayment for doctor visits, prescriptions, and we also have a voluntary $5 copayment for non-emergent use of the emergency room. The providers can choose to collect these, but it is voluntary. They cannot deny the services if the individual does not or cannot pay, and so they rarely collect. To the extent that they do collect, it is payment on top of whatever they might receive from the Medi-Cal program. There are also multiple exemptions to our current copay: children, pregnant women, ER use, and family planning services. The administration's proposal is to implement mandatory copays. These would be $5 for doctor and clinic visits. For pharmacy, there would be 2 types of copay: a $3 copay if the drug is on our preferred list or our contract list, and $5 if it is a non-preferred drug. For hospital inpatient, $100 a day, but with a maximum of $200. For use of the emergency room, for both non-emergent and emergent use, a copayment of $50, and for dental services, a copayment of $5. Under this proposal, the provider would be able to collect the copay from the individual, or in most of these circumstances can deny that service. There is an exception, of course, under federal rules for visits to the emergency room. Under fee-for-service, what would happen is that our fiscal intermediary would reduce the amount of the payment to the provider by the amount of the copayment, whether the provider has collected it or not. And in managed care, we would adjust our capitation rates for the actuarial equivalent with the assumption that the providers are collecting the copays. Our proposal doesn't allow for any exemptions for any of our beneficiaries. There was a question about why these proposals would require a waiver, and that is because current federal guidelines does have several restrictions on how states can choose to implement copayment requirements. They are restricted for certain services. So, for example, services for pregnant women are restricted. Services for preventive care for children are restricted. Certain population groups, it's unenforceable. So there's a long list of conditions that a state has to comply with for a copayment. Our proposal does go beyond those federal guidelines, and for that reason, it would require a waiver, and we would not be able to implement unless we receive federal approval. I did want to point out, and this is captured in the agenda, that our original estimate for savings on the dental services copayment was understated because we had only included adults. We have revised and provided those numbers to the committee so that it does also include children and pregnant women and people in nursing homes. And as a result, the total fund savings for current year would be $9.3 million, and for budget year, total fund savings would be $55.8 million.
And that's for dental?
Yes, for dental. Any other questions?
Any questions of committee members? Mr. Monning.
Thank you for the framing of these issues. Have you calculated any added expense to the handling and administration of cash payments at clinics and hospitals, primarily at community clinics, and any attendant additional costs to managing cash flow at community-based clinics?
No, we have not. It would be similar to what many of us today who have copays would be, in that we would show up, register for the visit, and at that time the provider would ask us for the copayment. But we have not factored in additional costs to providers.
Thank you.
Finance.
I know this topic was raised earlier in the Healthy Families portion of the agenda, so we've assumed that it would take 7 months to implement these proposals based on the time to seek federal approval and provide notice to providers and beneficiaries.
As stated on page 23 of the agenda under the questions, did Finance or the Department look at providing any kind of fiscal analysis with a reduced copay, either $2 or something else in place of the proposed $5?
The department is crunching the numbers on this. Unfortunately, I don't have anything for you today.
All right. LAO.
Madam Chair, members of the committee, Ross Brown, Legislative Analyst Office. Given the state's fiscal condition, we recommend the committee reconsider these proposals and, in addition, consider some alternative proposals. However, I do want to go over some broad concerns we have with these proposals, many of which have already been discussed. We believe there may be some level of difficulty associated with obtaining federal approval and obtaining a waiver to waive a lot of the federal requirements. We also, as has been mentioned before, think that some of the savings estimates may be overstated due to the failure to account for cost shifts. We also note that proposals may disproportionately affect the medically fragile beneficiaries. And finally, that the proposed copayments may, in some cases, effectively produce provider rates due to the way that they're being implemented, similar to what we discussed in the Healthy Families portion of the hearing. However, given, as I said, given the state's fiscal situation and the limited options in the Medi-Cal program, we recommend that you consider these proposals and consider some alternatives that we provide. Specifically, consider lower co-payments, particularly for the $100 inpatient hospitalization and the $50 co-payment for emergency services. We feel that these are excessive given the population. And we also suggest that the legislature consider implementing a cap on beneficiary co-payments similar to the Healthy Families program, and out-of-pocket cap on co-payments. We note that all of these alternatives may result in lower savings and additional administrative burden on the department, but they also may have less of a negative effect on the beneficiaries.
Any questions from committee members? Mansour.
Thank you. Thank you, Madam Chair. Under background, it mentions that enrollees have a voluntary dollar co-payment and services cannot be denied if the enrollee does not pay. Do you know how many people comply with that? How many people pay or don't pay? Even just the dollar?
We don't have that information, and we suspect that it's slim to none, frankly.
Thank you.
So at this point, we're opening it up to public testimony. I've received several notes from people asking if we're going to limit testimony to a number, limit it to a number of witnesses. It's not my inclination to do that, but I'm also looking at the hour and I'm looking at the heft of the remaining agenda items we have. With that, I'm asking you to self-police. I see a number of my fellow seasoned health advocates in the line. I'm asking that if you have consumers here or folks who've traveled, that you let them speak first, and that I'm going to try to reduce you to 30 seconds. Again, if there are consumers or others here, we'll try to extend the time. Again, it's not my desire to limit the number of witnesses, but I'm really going to ask you to work with me in terms of being concise in your testimony. Thank you. First witness.
Vanessa Hina with the Western Center on Law and Poverty. Really quickly want to make 3 big points about this. One is that in my research thus far, this would be asking CMS to set a really dangerous precedent on the mandatory nature of copays given in a waiver to a state. You know, some states have been given access to do some cost sharing with their Medicaid beneficiaries. However, the mandatory nature of it has not been seen yet in the research that we have accumulated. Second is that even nominal copays have a very deleterious effect on Medicaid beneficiaries' health. When a RAND study was done, about 10%, with older people at risk of heart disease, they had a 10% increased risk of death when they were faced with a nominal copay. And third, I just want to give you a really brief overview of what a Medicaid beneficiary looks like. We're talking SSI recipients who are getting $845 a month. We have a proposal to cut that to $830 a month. We're talking about CalWorks families who are getting about $500 or $690 a month. So when you're a CalWorks mom with 2 kids and your son comes home with an eye infection or pink eye and gives it to his little brother or little sister, that's knocking out your rent for the month. So we ask you to consider all of these things, especially the part about the waiver. This is a really dangerous precedent.
Thank you.
Beth Capel on behalf of Health Access California. These proposals will make families homeless. When I became an advocate 25 years ago, the most common cause of homelessness among families was medical costs. This will return us to that day. In addition, the federal guidance, and I want to focus specifically on the hospital services here, limits out-of-pocket costs to 5% in a month or a quarter. This is well in excess of that. Also, it requires the state to track the cost sharing, which the state apparently is not doing by their own testimony, how much is being withheld. So we need a system for that. And I would also note, having reviewed the federal guidance recently, which I gather this department has, that $3.40 is the copay that's supposed to be levied for services that cost more than $50. That's a far cry from $100 a day for hospitals. Thank you.
Thank you. Next witness.
Thank you. Carolyn Jenna with the California Medical Association. In the interest of time, I'll comment on two of the copay proposals before the committee today, and that's both the physician visit proposal as well as the emergency and hospital copays. For purposes of the physician copay, how a member or how one of our physicians is going to decide when they walk into a waiting room full of people, all of whom are on Medi-Cal and all of whom owe them presumably $5 to be able to be seen. If somebody has it and somebody else doesn't, do they turn them away? No. And in our experience, what they do is they just stop participating in the program entirely. And again, we're getting into just exacerbating the access problem we already have for Medi-Cal enrollees. For purposes of the hospital side, what those patients then do when they can't get seen by a physician or in a clinic, and they end up being seen in the ER, and there's a copay proposed for that. But hospitals and doctors working in the ERs cannot refuse to see them if they don't have the copay. So it just becomes a cost shift onto an already overburdened system, and we're going to have more costs in the future as a result. Thank you.
Brandon Tartaglia with Disability Rights California. Many people who get Medi-Cal can't afford any co-payments. This proposal would put people in a situation where they have to decide, should I fix my rotting tooth or should I get my prescription? Should I get my prescription or should I eat dinner? This is going to cause worsening health conditions and cost us all more in the end. We urge your rejection. Thanks.
Thank you. Next witness.
Good afternoon, Chair and members. Allison Ramey on behalf of the California Primary Care Association. I want to begin by saying that for years we've been trying to encourage people to seek preventative care because it's the right thing to do. It lowers the overall cost to the health system. And imposing co-pays on all of these services, including primary preventative care, goes very much so against that. Additionally, I'd want to add that for federally qualified health centers, we do not have the ability to turn away patients, nor would we want to if they can't pay that $5 copay. So this does amount to, as Ms. Janot pointed out, another rate reduction.
Thank you. Next witness.
Good afternoon. Stephanie Needzayu with Planned Parenthood Affiliates of California. We are also opposed to the copays. We believe that assessing a copay on family planning services as well as pregnancy-related services will just become a barrier to these mostly women accessing service. We also are concerned that it would run afoul of federal law, that applying a copay to family planning or pregnancy-related we would no longer be in compliance, and that is of concern. So we would ask that people look at that. We believe that the provision in federal law actually is not subject to a waiver, so we hope that the state can take a look at that. Thank you.
Thank you.
Kathy Mossberg representing the California Family Health Council. We would agree with our colleagues representing the other clinic associations. Family planning services and pregnancy-related services are needed and cost-effective, in addition to the fact that on the family planning services, we draw down a 9-to-10 match on both the Family Pack side and the Medi-Cal side. So it would be extremely penny-wise, pound-foolish, as you've heard in many of these hearings. So we also would agree with our colleagues that these are not waivable items at the federal level. So eventually we would see that come down.
Thank you. Next witness.
Hi, Erin Auber-Givens on behalf of the Children's Specialty Care Coalition. We represent over 2,000 pediatric subspecialists in the state who are devoted to taking care of kids in Medi-Cal and CCS, the California Children's Services Program. This copay proposal, along with the prescription proposal, would apply to children, even the sickest children. We did a quick analysis with families trying to add up the number of visits and prescriptions, hospitalizations, ER visits they have annually. And for example, for a child with several chronic conditions, cerebral palsy, reflux, asthma, and epilepsy, the copay amounts would be almost $1,600 in totality with these proposals. For a child with a single chronic condition, it would be just under $600 a year. Families cannot pay this. We don't collect the dollar copay now because families can't pay the dollar. This would be devastating for kids in CCS. We urge you to oppose this. Thanks.
Thank you. Next witness.
Madam Chair and members, Peter Gamby on behalf of the Association of California Healthcare Districts. We are opposed to these proposals for reasons previously stated by others. In addition, we would like to point out that as hospitals, we are federally prohibited from even discussing someone's insurance status prior to the time we deliver care. So all payment has to take place upon discharge. The vast majority of the people we're talking about here simply cannot afford co-pays of this size and will not pay. So this is, in effect, just a rate cut to hospitals.
Thank you. Next witness.
Madam Chairman and the committee, my name is Ekaterina Burton, and I'm from the Alameda County Community Food Bank, which is a part of the California Hunger Action Coalition. And on behalf of the California Hunger Action Coalition, we urge you to not enact these proposals because ultimately they will lead to more hunger and food insecurity throughout this state for reasons you can easily surmise. Already in Alameda County, we are serving 1 in 6 residents. This will get higher if these proposed co-payments are enacted, among other cuts, and it's in the long term not sustainable for food banks or our state. Thank you.
Thank you. Next witness.
Randy Hicks for Californians for Disability Rights. We agree with everything that Disability Rights California said for disability community. As a personal story, I went to the hospital. I didn't have my $5 copay. They said, "You have $5?" I left my wallet at home. Okay, so now what do you do? Now you can't pay? It's embarrassing. You're standing at the window. You go, what do? You cancel the appointment? How long did it take you to get there? For some people, for Terra Transit, it's a $10 ride. For some people, for RT, it's a $7 ride. You get there, you've spent all your money on getting there, but then when you get there, you don't have the money to pay. So, seriously, I think there's a better way of doing this.
Thank you. Next witness.
Hi, I'm Joel Cohen with the Center for Oral Health. For the last few years, the dental community has been trying to improve access and utilization amongst the communities in California. And item 6, which would put the copay on dental services, would have a dramatic effect on both these issues. We strongly encourage you to reject this. Thank you.
Thank you. Next witness.
Good afternoon, committee, fellow witnesses. I'm John Wilson. I'm a volunteer with the Alameda County Community Food Bank and the California Hunger Action Network. I'd like to share with you some of my stories and experiences at the food bank as part of the safety net, specifically over the last 2 years. I've noticed things like the food bank, there's many people now turning to the food bank that never would have imagined it a few years ago. Many people who would consider themselves upper middle class, rich even. Never would have thought turning to the food bank. It serves the whole community. People now at the food bank are there because they don't have any money to buy food. So to ask them to come up with more money for basic medical services just doesn't seem, it seems like a difficult proposition. The other thing I'm noticing at the food bank is as we speak, it's gone from about a 2-acre facility to nearly a 3-acre facility, and this has just happened. We're implementing our rainy day plan. We think it's going to get worse. I would like to leave with this thought in terms of, as we go through the next few weeks, don't think of this as a fiscal crisis. It's a fiscal shortage, and there's a difference between a crisis and a shortage.
10 seconds.
And some answers are obvious. For example, we've been talking about a copay for medical services. How about a copay for gas extraction services? There's a lot of other ways to implement and restore our revenue, which is the problem.
Thank you. Next witness.
Alex Graves with the Alzheimer's Association. We're in opposition to these proposals. Thank you.
Thank you.
Beth McGovern with the California Commission on the Status of Women. The proposed copays would negatively impact access to health care, and the majority of those who would be negatively impacted are women, mostly women of color, and a whole lot of single-parent households led by women. So when we're talking about cuts to Medi-Cal, those are the people we're looking at. We are opposed to the mandatory copays.
Thank you very much. Next witness.
Missy Johnson with the California Retailers Association, also in opposition to the mandatory copays for Medi-Cal pharmacy services. In opposition largely for the reasons stated previously, but more importantly, we have a question as to how these copays would work. While federal approval can be obtained for the imposition of copays, the federal law also explicitly prohibits the collection of copayments from a number of populations. So we're not really sure how that would work in a practical setting. How's a pharmacy to know who they should collect the copay from and who they shouldn't? So we have those unresolved questions, and that's why we're opposed. Thank you.
Additional co-payments when I have co-payments for my meds and for doctor visits and other things
We can't afford it. No more co-payments. It's just like cutting us in a different way.
Right.
The co-payments are cuts. They're taking more money out of our pockets. So please consider it. No more. Thank you.
Next witness.
Madam Chair and members, Barbara Glazer with the California Hospital Association. We too are opposed to these co-pays, particularly the co-pays for hospital ER visits and hospital stays. They're very high co-pays. It's not reasonable to assume Medi-Cal enrollees will have that kind of money. I'd also like to mention that the proposal assumes a decreased utilization in hospital days. Respectfully, we disagree with that assumption. There is already a process in place, the TAR system, which keeps in check hospital stays. We think we'll see more. We think this will result in a decreased payment for hospitals.
Thank you. Next witness.
Madam Chairman and members, Nathan Mansky representing Adventist Health, Loma Linda University Medical Center, and also the Private Essential Access Community Hospitals, which is a association of safety net hospitals around the state. And I would agree with comments made by Ms. Glazer from the California Hospital Association, and we oppose, for those reasons, we oppose the mandatory co-pays. Thank you.
Thank you, sir. Next witness.
Madam Chair and members, Sharita Lane with the California Children's Hospital Association. We also are opposed to the mandatory co-pays. The chronically ill, seriously ill children that are seen in our hospitals are subject to many visits and hospital stays, and they just are not going to be able to afford these co-pays. And coupled with the provider rate reductions, which we will discuss in a moment, it's going to result in even further reductions to hospital reimbursement, which is going to affect access to care for all Californians, not just those on Medi-Cal. Thank you.
Margaret Merritt with the American Congress of Obstetricians and Gynecologists. We're also opposed to the co-payment recommendations. The burden that the co-payment would put on the women and the doctors that would like to serve them would further exacerbate access to care.
Thank you.
Thank you, Madam Chair and members. This is Fred Note. We're representing the California Dental Association, and consistent with my earlier testimony, I think we're very concerned about how these co-payments would affect the underlying program of what's left in California for dental care, particularly those populations that are left being served, namely pregnant women and children. And so this would be clearly an adverse impact on them, and as I said, because of the drip, drip, drip takeaway of dental services, and there's not much left, we have grave concerns about the underlying viability of the Denti-Cal program. Thank you.
Thank you. Next witness.
Frank Welty from the California Council of the Blind. Because many blind and visually impaired Californians have limited incomes, we oppose these proposed co-pays. Thank you.
Thank you. Thank you to the witnesses. Any questions or comments from the committee?
I'd like to make one general comment that I haven't made so far this year in this subcommittee, but it's sort of general to all of the Medi-Cal cutback proposals, and that is that everything that reduces access all over the state does so even more so in underserved areas because there's a shortage of practitioners, whether it's a low-income urban community or, as in my district, rural communities where attracting providers is a huge challenge that we've all been trying to figure out how to incentivize it. And when such a large percentage of the population is Medi-Cal, making it harder to be a Medi-Cal provider just means there's one more weight on the side of a provider deciding not to go to an underserved community and instead to try to go someplace where there's more paying or insured people to help counterbalance the cost of providing subsidized care to the low-income people to save the state money. So it's an access issue for underserved communities as well. I just wanted to make that point.
Thank you, Mr. Chesborough. Any other comments? It's the chair's suggestion that we hold all of the issue items just presented open, and that's issue items 3 through 6. Moving on to issue 7, the elimination of cough and cold products, adults.
Over-the-counter drugs are an optional benefit in the Medicaid program. Last year in 2010, the previous administration proposed the elimination of several over-the-counter drugs. The legislature approved the elimination for adults of drugs, over-the-counter drugs that contained acetaminophen. This is taking it a step further, and we are proposing the elimination of over-the-counter cough and cold products. If you have any questions, I'd be happy to take them.
Finance?
No additional comments on this one.
Elio?
Given the state's fiscal condition, we recommend you adopt this proposal.
Any other questions from the committee? And in seeing no public comment, we will hold this item open and move on to 8, elimination of adult day health.
The Adult Day Health Center program is a program under Medi-Cal that provides health and social services through a bundled program over a 4-hour period. We have in California, on an average monthly, 27,000 users of the program offered through 325 facilities. It's a valuable program providing home and community-based services in our spectrum of services to provide opportunities for individuals at risk of institutionalization to reside in the community. Given our fiscal crisis, we are proposing to eliminate the Adult Day Health Center program. Under federal rules, there are benefits under the Medicaid program that are mandatory, that all states must provide if they are going to participate in the Medicaid program, and there are other services that are optional benefits. The Adult Day Health Center program is one of those optional benefits that states can choose to provide or in many cases not offer. We are one of 8 states that offer this benefit as a state plan. There are other states that might offer it as through managed care services and others as a type of adult day health center, but one of 8 states that offer it as an optional benefit. These services are definitely not optional for the individuals that receive them, and there will be impacts both to the beneficiaries, to the families that depend on these services, as well as to the centers and the staff. But again, given the fiscal crisis, we're proposing to eliminate it. We have looked in previous years at ways to contain costs and focus on the most individuals most in need by tightening the medical necessity criteria, limiting the number of days, reducing the payment levels, freezing the payment levels. In all those instances, they were enjoined by the courts. There was a question about reducing payments again. That is always a potential proposal. It obviously wouldn't result in the same level of savings. There would be potential litigation factors that would have to be looked at. As with any payment reduction, there are issues around adult day health center rates being tied to nursing facility level A rates, so trying to delink that from a previous court decision would have other potential risks as well. So at that, I'll open up to questions, and I know we have many.
Mr. Chesborough.
I'd like to ask you a question, and also when the LAO's turn comes to ask the LAO the same question. Can you talk for a moment about the origins of the program, why the state got into it, and was it not as a cost savings alternative to reduce the cost of the state of institutionalization, either in developmental centers or nursing homes?
Unfortunately, I don't have the history on that. I will, as I did state in my testimony, I will reiterate, it is definitely, we have an array of programs, both those under state plan as well as waiver services within our department, within social services, that are all focused on providing individuals the ability to receive health and social services in the community to reduce the risk of institutionalization. And this has been part of that approach and a part of our ability and our commitment to maintaining compliance with Olmstead. We believe there are other services, and eliminating this will still preserve other opportunities, but there will be impacts.
One thing I appreciate about you is that you've learned to anticipate all of our questions, so you're answering them in your testimony. I always have this long list of questions, and it used to be I'd have to ask them one at a time, but that was the only one that I had left that you hadn't gotten to. So.
Ms. Yamada.
Yes, just one comment. I know there's a long line of witnesses, but to the director, who I know is also a constituent of mine, what effect would you say has the moratorium had on this program? And perhaps maybe Finance or LAO might have a comment on that as well. But there's been a moratorium on this program since 2004, I believe. Is that correct? And so this sort of de facto, closure, if you will, on the door to these services sort of already, been in effect. Do you have any information or, experience as to what effect this moratorium has already had on this very important program?
Ms. Yamada, when you say moratorium, do you mean that they capped enrollment?
No, ma'am. What I'm saying is that there has been a moratorium on new licensure for adult day since exactly.
Okay. All right.
Thank you.
Yes. Since 2004, the department, after a lot of reviews of the Adult Day Health Center program in terms of programmatic integrity and fiscal integrity, found that there were many facilities, not all there, and you're going to hear from a lot of great facilities out there, but there were facilities that were not following the rules, and it was a decision by the previous administration to institute a moratorium. And that has resulted in a reduction in the number of facilities. That we were, at one point a lot closer to 400 facilities, and it has gone down, declined the number of facilities. Participants have increased, and not at the same pace they were previously. I have not heard, and we do not receive instances of beneficiaries not being able to access adult day health center services. There clearly are areas of the state that do not have adult day health center services available. There were exceptions in the moratorium to make sure that there would be at least one in every area, but certain areas where they have closed, they haven't been able to keep up the capacity. But we haven't heard large instances of impacts from a beneficiary perspective at this point.
The comment I'd like to make, Madam Chair, is that I have, both as a previous chair of Health and Human Services over on the Senate side and also as an author, worked very closely with the adult day healthcare community, and they have accepted significant, and I'm sure they're going to talk about them, so I'm not going to go into detail, but significant cost containment over the years. And so it's already been a great price paid, both in terms of, on the one hand, some efficiency and some rooting out of some problems, but on the other hand, a reduction in service that has already taken place, and they're much more qualified to talk about those impacts than me. But I just did want to acknowledge ahead of time that it's not just a baseline of, they've been left alone. Hardly.
Yamada.
Didn't have anything else at this time, but actually one question did pop into my mind, and that is the previous reductions have, as you mentioned, been enjoined by the courts. In these savings that have been scored by the elimination, was the cost of suit factored in at all?
No, it wasn't. It was not factored in. It was.
Okay, thank you.
Finance.
As has been noted, the state has been sued both in the ADHC program and other programs where we've attempted to target services to the most needy beneficiaries, and it puts us in the undesirable position of where to try to contain costs within the program, we end up proposing the outright elimination of benefits because the state has been successful in those lawsuits.
LAO.
Thank you, Madam Chair. Meredith Worden, LAO. Due to the state's fiscal situation, we are recommending that you approve this proposal. We recognize that this will have significant impacts on beneficiaries. We also note that a reasonable argument can be made that this proposal would potentially run afoul of the Americans with Disabilities Act, and as such, a transition plan would likely need to be put in place if you choose to eliminate this program. The state also has alternatives to achieve savings. We have noted that as an alternative, you may wish to direct the department to pursue a federal waiver to more target this program to certain beneficiaries. However, the amount of savings that could be achieved from doing such is likely to be reduced and in the out years. Additionally, we have recommended that the administration come forth with a net savings amount, that the savings in the budget is a bit overstated.
Mr. Monning.
Thank you, Madam Chair. Have any of your departments analyzed the impact of family members having to leave paid employment to take care of the disabled senior who leaves the adult daycare program, and the number of lost jobs to people currently providing those services, impact on state revenues?
And we in the Department of Healthcare Services have not looked at that impact, acknowledge that there could be those types of impact, and likely will be those types of impacts.
And for me, I guess this is really more of a rhetorical question, but my assumption is nor has there been any kind of a cumulative view recognizing all of the cuts to the same population contained in the administration's proposal, between cuts to in-home support services, the MSSP program, adult day health. That kind of more global view in terms of impacts of this population has not been done either.
No, that has not been done. I would say, I don't know off the top of my head. There is some overlap, and in most cases someone on ADHC is not on MSSP. There is more overlap between ADHC and IHSS, so that there could be some cumulative impacts, likely will be.
I would assume that'd be, Madam Chair, a major component in the discussion in an Olmsted case is to what degree does the cumulative impact in combination of rolled back services ultimately result in a violation of the rights under the Americans with Disabilities Act to live in the community.
So before we move into public testimony, let me say that this stack today represents about half of the letters the committee has received from people expressing their concern, both handwritten letters, personal testimonials, family members who are expressing their deep concern with the administration's proposal. I will remind you again what I've said previously about your testimony. You'll be limited to 1 minute, and I actually have a button here that says priority that allows me to cut the mic. Please don't make me use it. 1 minute, first witness.
Good afternoon, Honorable Chair, committee members. My name is Nina Alcox, and I'm a registered nurse and public health nurse who has worked in skilled nursing facilities, acute care, critical care, and home health settings. Years ago, when I was introduced to the adult day health care program, my immediate thought was, this makes sense. Finally, a health care program that meets the health care needs of the frail, medically complex patient via a multidisciplinary team approach. These chronically ill populations are the same ones that would frequent ERs and face unnecessary institutionalization without ADHC interventions. Chronic illness combined with lack of medical skilled oversight and interventions result in higher cost reactionary care, which is how most of healthcare systems function. One of 1,000 examples is a 40-year-old patient who is a brittle diabetic. His glucose levels are labile with day-to-day variations that prior to adult day health care resulted in EMS activation and ER visits 2 to 3 times a month. As a result of skilled interventions and ADHC, including close work with specialists and primary care physician, this patient is managed in our setting with standing orders for insulin administration and treating dangerously low glucose levels in our setting without activating EMS or an ER visit. This allows his 79-year-old grandmother, who is his primary caregiver, to continue to take care of him. Elimination of this program it makes no sense whatsoever. It will definitely cost the state more money.
Thank you very much.
Good afternoon, Chair and members of the committee. Thank you for the opportunity to have testimony. And I, on some level, feel like I don't need to after hearing what you had to say. I do need to make a comment about what Finance had reported in terms of that there have been other successful lawsuits winning complete eliminations. I'd like to point out that those complete eliminations were for one service. Adult day health care has skilled nursing, has social work, has physical therapy, speech therapy, occupational therapy, registered dietitian. So you're talking about a whole network of things that are in violation of the Americans with Disabilities Act. So those are two totally different things. And I would like to point out that in Contra Costa County, there are 3 adult day health centers. They would close their doors. That would mean it's not only Medi-Cal, it's private pay, it's the veterans we serve, it's the regional center clients we serve. You would be wiping out $300 million in the state of California's investment in this infrastructure. It's like putting your money in the stock market and pulling it out the day it crashes. Thank you.
Thank you.
Hi, thank you again for the opportunity to speak to you. I'm Dr. Barbara Porter. I'm a psychologist by training, but I'm the program director at Inland Empire Adult Day Healthcare. I want to address a very specific population that seems to be ignored in the adult day healthcare system, and that's the chronically mentally ill, and in particular, those who have Medi-Cal only. In San Bernardino and Riverside County alone, there are 200 minimal, and that's just us, who have only Medi-Cal. Without arguing with what the administration is saying, I want you to know there are no other services besides going to the psychiatrist maybe once every 3 months and then decompensating and ending up in a psych ward. If you understand the difference between $38 a day in adult day health care and $1,500 a day basic in a psych hospital, and if you look at the research, the National Institute of Mental Health says 10 to 30 days is the average stay of somebody who decompensates. So I'm looking at it and I'm saying, wait a minute, where's the logic of actually comparing those two systems? I implore you to take this seriously. This is a population that is vulnerable, and I hope and pray that if this gets eliminated, that nobody has to live with a California style of Tucson on their conscience. Thank you very much.
Thank you. Next witness.
Hello, I'm Lucy Nalbandian. I come from Los Angeles. I work for a center called St. Barnabas Senior Center of Los Angeles. St. Barnabas is the oldest senior center in Los Angeles, 102 years. And seems the people who need care will come to us, any kind of disabilities, seniors, etc. We introduced the Alzheimer's Daycare Resource Center in 1989. We lost the funding for this program last year because governor decided to eliminate the funding for Alzheimer's Resource Centers. We cannot afford losing Adult Day Health Care Center, which is a center we have since 2003. We serve a really frail population. They belong to nursing home. We did a survey. If we close our doors right now, out of our 70 current participants, 70% will end up in nursing home right away. The rest will end up in emergency hospitals or maybe have hospital visits within next 3 months. And most probably 40% of our participant caregivers who are working caregivers will decide either to quit their job to be able to care for their loved ones or take their loved ones to the nursing homes. We are very multi-diverse and very multicultural center. We speak 13 languages here. And majority of our population comes from traditional cultures. They cannot accept taking their loved ones to the nursing home. And the 102 caregivers who know about the elimination asked me to present their voice here. They are probably, you have letters maybe from them too, but the message is very clear. They cannot be burdened to their families. If they don't go to nursing home, then we bear the moral hazard. So these people, we have cases where seniors would say, we'll commit suicide. We cannot be burdened to our families.
Thank you very much. Thank you. Next witness.
Good afternoon, Allison Ramey on behalf of the California Primary Care Center, or Primary Care Association, excuse me. Of the several hundred adult day health centers in California, 14 of them are operated by our members, serving approximately 2,000 patients. What we've been told time and time again from our members is that the comprehensive care that they provide to the recipients at ADHCs cannot be continued without this funding, without this program. And if this program is eliminated, the health centers shut down. And as such, we have added ranks of the uninsured from unemployed, losing their jobs from these adult day health care centers not functioning any longer. So please reject. Thank you.
Thank you. Next witness.
Barbara Glazer with the California Hospital Association. We believe the elimination of this program will result in increased admissions to the emergency room, increased hospitalizations, increased admissions to skilled nursing. We're not sure where the savings are in this proposal. Thank you.
Thank you. Next witness.
Brendan Tartaglia with Disability Rights California. We oppose this elimination because of the increased risk of institutionalization and increased cost to the state. Urge rejection. Thanks.
Thank you. Next witness.
Hi, I'm Nance Rosencrantz, and I'm here because I was the primary caregiver of my husband, and I can't talk about it very well because he died. But he was an attorney in San Francisco for 30 years, and then he had dementia. So we had caregivers in our home, but I felt that his care was better in the adult day health center. We paid out of pocket, and we are not a Medi-Cal recipient. But I came here today not only on behalf of the Medi-Cal recipients, but also on the behalf of all of us who have aging parents and husbands, and we need this infrastructure in our communities. If you look at the growing number of seniors who are going to need this program in the future, to eliminate the revenue that comes from the Medi-Cal beneficiaries would basically gut the program, which hurts all of us, not just the Medi-Cal beneficiaries. Thank you.
Thank you so much. Next witness.
Madam Chair and members, Carol Risley, State Council on Developmental Disabilities. The situation here is, again, a cost shift and also an issue about cumulative effect. We know that the cost of institutionalization in our system is over $300,000 a year per person compared to someone in the community that's often under $50,000 and even at times less than that. We recognize that the message is that the DD system is going to be backfilled, but backfilled to a system that in 2 days you're going to be hearing, or you already have heard perhaps, that it's got a $533 million net proposed reduction. Backfilled to what? These services will close, and we will have to reopen institutions.
Thank you.
Randy Hicks of Californians Disability Rights. And this came from Californians Disability Rights. According to this, home-based services save over $1 billion a year. The state, $1 billion. The second point I'd like to make is, assuming higher level costs, reducing care costs by conservative $20,000 a year, and it would cost counties $400 million a year, according to the CMS, County Center for Medicare and Medi-Cal Services. So just score those savings alone. Just look at how much that's costing. $1 billion.
Thank you, sir. Next witness.
Hi, good afternoon, Madam Chair and committee members. My name is Christy Hernandez on behalf of Ultimate Health Services and the 137,000 patients that we serve. I'm here today to plead for people's lives and people's jobs. People's lives, 1,400 participants at Ultimate Health Services, 37,000 statewide. People's jobs, 225 at Ultimate, 7,600 statewide. Caregivers, a projected 10,000, possibly more. Contractors, vendors that have contracts with adult day health care centers, that's 300 sites. Also small businesses, not to mention the small businesses that we contract with, that would also be out of business. A Lewin Group report, also a fact sheet that you've been provided with, projected that in the first year, $51 million would be the cost to the state. Therefore, it would not be saving, but an additional $51 million. And that does not take into consideration nursing homes, increased hospitalizations, emergency room costs. And first and lastly, we believe that this is also, not lastly, but I'm sorry, we feel this is a bargain for the state of California. And this is a moral outrage. Participants want to be able to live in the comfort of their own home, and ADHC allows for that. They don't want to be a burden on their families, as mentioned before. This allows them to contribute back to their communities. This is one of the most quickly and, it's rapidly growing. There's a person that turns 65 years of age every 8 seconds, and therefore this would be the perfect storm, as we say. And therefore we ask that you please oppose and reject the proposed elimination of adult day health care centers.
Thank you for your testimony.
Thank you.
Hello, my name is Mallory Vega. I'm the Executive Director of Acacia Adult Day Services. We're in Orange County. We are a nonprofit. We provide both adult daycare and adult day health care services. In 1979, we started our first center in Garden Grove. In 2004, we started a center in Cypress, and we are one of those casualties. Our Cypress site is in terms of closure. We lost half of the enrolled individuals in that program to situations where the families tried to cobble together care. Individuals were too frail to be able to transition to our Garden Grove site, and the rest went into convalescent hospitals. Because we are nonprofit organizations, and many of them are, that center, it took us 9 years to get that center open. We do not have 9 years to restart all these programs once you shut them down, and it's estimated it costs about $1 million to open one. Very foolish in terms of cost savings as a Medi-Cal program.
10 seconds. Oh, thank you.
Good afternoon. I'm Diane Cooper Puckett, and I'm the founding executive director of the Peg Taylor Center for Adult Day Health Care. We're located in Butte County, and we're celebrating our 25th anniversary this year. I've had the privilege of being there from the very beginning, and I know that we were started by community volunteers by the inspiration of those folks who looked out in the rural counties and saw no services. We now serve Glenn and Tehama as well as Butte County because there are no such services out there for people. If in those counties, in the areas that we serve, we have as many as half of the residents of the counties have chronic, serious health conditions. In parts of the area that we serve, a third of the folks are over the age of 65, and many of them are in their 80s and their 90s. So there is a tremendous need for our program, but after 25 years, if this proposal passes, our program will disappear. And where will the people that we serve go to then? They might go to hospitals, they might go to emergency rooms, they might go to skilled nursing. In many of their areas, there are no such services. So they will leave their communities to get care, or they will die.
Thank you.
Good afternoon. My name is Judy Simmons, and I'm here to represent my sister. She's 71 years old. She's schizophrenic, diabetic, and a leg amputee. These are all high-risk, high-cost conditions. We were able to find housing for her 20 miles from where I live and where she goes to the Peg Taylor Center. Then they were able to take her SSI as her housing payment. Prior to being able to go to the Peg Taylor Center and live in this living situation, she was in 2 full care facilities, one here in Sacramento and one in Chico. My concern is that if you eliminate the funding for this program, she will go back into a full care facility, and it will certainly shorten her life. So please preserve the adult day health care through the Medi-Cal program. Thank you very much.
Thank you.
Madam Chair, members of the committee, my name is Mark Woodruff. I am the program director at Casa Pacifica Adult Day Health Care Center down in San Diego. I am blessed to be able to provide skilled services to some of our most frail adult day health care providers on a daily basis. We're doing upwards of 140 diaper changes per day. Last week, the Senate budget consultant stated that home health services, IHSS, community clinic services, medical therapy services, and physician services are similar to adult day health care and could substitute if we are eliminated. On behalf of my frail, nonverbal patients, I want to set this record straight. These 5 fragmented, independent services recommended to the Senate subcommittee last week do not offer the efficiency or the clinical oversight to prevent expensive institutionalization. There exists no incentive for any of these 5 fragmented services to coordinate a critical plan of care.
10 seconds.
There exists no case management or transportation. Speaking from experience, there is no substitute to adult day health care. Please reject the governor's proposal.
Thank you.
Alex Graves from the Alzheimer's Association. We're also opposed to this proposal. 20 years ago, if you had Alzheimer's, it was all but assured you would end up in a nursing home. And today, thanks to programs like this, less than 6% of people with Alzheimer's in California are living in a nursing home. This is significant considering that the cost of Medi-Cal for an individual with Alzheimer's is 2.5 times greater than an individual without Alzheimer's. And as one or two people have mentioned, as the baby boomers are starting to turn 65 this year, this is an infrastructure that is really critical that we continue to support and keep. Assemblymember Chesbro asked about caregivers. I happen to be carrying our facts and figures, which I'm happy to leave with you, but it does have some information on that. I'll just very briefly, 21% of unpaid caregivers report being forced to miss work, 8% report reducing their work hours, 11% report quitting their jobs, and 4% change their jobs due to the caregiving demands. And families provide almost 3/4 of the value of informal and formal care for individuals living with Alzheimer's disease, and $72.7 billion out of an estimated cost of over $104 billion is attributed to the unpaid caregiving. So I'm happy to leave
Please
these
do.
for you.
Please do. Thank you. Next witness.
Madam Chair, committee members, my name is Mark Kovalik. I'm administrator of Among Friends ADHC in Oxnard, Ventura County. With only a small percent of ADHC mental health patients requiring IMD hospitalization and a small percentage of frail elderly requiring nursing home care without ADHC services, all projected savings by the state are going to be wiped out and will cost the state hundreds of millions more than the entire ADHC budget. According to Lewin Group report, this cost will be $51 million more than projected saving. And this is just this fiscal year. And this budget increase is expected to grow to $72 million by 2020. Elimination of ADHC will also have a negative impact on large number of small businesses that currently conduct business with ADHC. I'm talking about all the, vendors and providers, food providers, automobile, services providers.
10 seconds.
And this, in not some, it's going to lost business will account to about $122 million to the state, which will result in $15 million in the state income taxes. And I just want to lastly say that last week in the State of the Union address, President Obama, said that we have to cut waste and create savings, but not on the back of the most vulnerable population. And this is exactly what this proposal is intended to do.
Thank you.
Thank you.
Next witness.
Hello, committee. Good evening. My name is Michelle Pope, and I'm the Executive Director for Alzheimer's Services of the East Bay. We're a 23-year nonprofit adult day health care that has provided services to individuals that have not only mental illness, but Alzheimer's and other forms of dementia. We serve 120 people a day at our 3 centers. Throughout those 3 centers, they're attached to 120 caregivers. Those 120 caregivers are attached to people who they work with. They also are part of that sandwich generation. I was here earlier listening to all the cuts to the children. That is affecting my families as well. As a pastor, I'm finding that more and more I have people coming that need food, that need shelter. Some of these people have dementia and Alzheimer's, but they haven't found adult day health care, or they haven't been able to go and fill out the forms, or they don't understand how to get a part of the system. And when the system is falling apart, I don't even know if they want to be a part of it. What I want to propose to you is you take a close look at the fact that adult day health care has been an optional benefit, but we are providing life-saving measures. Is life-saving optional? I don't think it is. So I just ask that you really take a close look at what it means about eliminating adult day health care as a model that has supported families, that has made it possible for somebody who can't remember what day it is, what government we are, or where they are, or any of that, that they matter. They matter. They paid for us to all be here today. So let's not throw them under the bus.
Thank you.
Let's not act like they're not dead yet.
Thank you. Next witness.
Madam Chair, committee members, my name's Tracy McLeod. I'm the program director at the Institute on Aging Adult Day Health Center. It's located in San Francisco, and we are one of the 5 pilot programs that were the first from the state to open adult day health care in 1975. I wasn't there then, but most of my colleagues here have said that there have been studies that show that, immediately with the closure of centers, 36% of our patients will go into skilled nursing facilities, which is fine and dandy if there are skilled nursing facilities available. In San Francisco, it's about 450 people of our beneficiaries that we serve over 11 centers that would go to that would need skilled nursing facility care. Unfortunately, we have no available Medi-Cal beds in San Francisco. Even if we did, the cost per patient is about $23,000 difference between serving them in adult day health, where they get care for only about 3 days a week, versus nursing homes where they're in there for 30 days a month. The cost to the state for adult day health care is $38.13. For nursing homes, it's $82.13. So if you do the math, in San Francisco alone, that's an additional $11 million to put these 450 people into nursing homes. When people's conditions deteriorate and there are not nursing homes available, they will use emergency rooms, which are already overcrowded, or they will languish in acute care hospitals until there are beds out of county available. Please do not eliminate adult day health care.
Thank you. Next witness.
Hello, members of the Assembly. My name is Kelly Folk. I'm the Chief Executive Officer of the Glenner Alzheimer's Family Centers in San Diego, one of 21 providers in that county. I'm here to talk to you today about the cost saving that ADHC has actually given to the state. In 2005, the ongoing moratorium realized 56 centers closed, and 11% of those patients were no longer in the program. In February 2008, we had tighter medical necessity criteria, and the number of patients served has declined significantly as a result of this tighter criteria as well as the moratorium. Patient count went from 42,000 in 2005 to the governor's projection of 27,000 in the upcoming budget year. ADHCs have also had a continuous rate freeze for the past 5 years. Our rates haven't increased, yet the level of care that we must provide has. In addition, the governor has budgeted ADHC for a 10% rate reduction for the budget year. Every day we are faced with a fixed reimbursement increasing costs that we have to manage within our budget without compromising care and safety. As noted, CADS has brought alternatives to the table for many years, working with you, your staff, and the administration to offer solutions that have resulted in cost reductions. We will have some ideas for streamlining and cost reductions for you by this Friday that will still protect the quality of care for our ADHC patients. I urge you to remember the sacrifices already made by our programs and the cost-saving benefit ADHC continues to be to the state. I urge you to vote no against the governor's proposal.
Thank you very much. Next witness.
My name is Carol Sewell, and I'm staff to the California Commission on Aging. While the Commission acknowledges the dire circumstances that the state faces as far as the budget goes, we recognize also the enormous value that adult day health care provides to the state and to our elderly population. We urge you to work with CADS on any proposals that they may bring to at least maintain program levels at some rate. They've been very flexible and very willing to offer compromise in the past, and we hope that you can accomplish that again. Thank you.
Thank you. Next witness.
Liz Helms, California Chronic Care Coalition. I concur with the eloquent testimonies that I've heard before me in imposing these cuts, and would like to give my extra seconds to the people still waiting to talk about their personal experiences.
I appreciate that. Next witness.
Good afternoon, Madam Chair and subcommittee members. My name is Tamara Schmutzler. I'm the Program Director of Alzheimer's Services, the East Bay. And today what I'd like you to hear, not so much my perspective, but the perspective of somebody with Alzheimer's and dementia. And if any one of my participants could stand here before you today, this is what they would say to you. Please, please don't eliminate my adult day health program that allows me to remain as independent as possible, improves my overall quality of life, allows me to engage physically, socially, and mentally in the act of living, and last but perhaps most importantly, allows me to retain my sense of dignity and self-respect. Thank you.
Thank you. Next witness.
Hi, my name is Lynn Yu. I'm a social worker at Alzheimer's Services of the East Bay.
And, you know, a lot of our families really heavily rely on our program because it allows the families to work during the day so that we could watch them during the day, right? So I could, you know, at least they have the time to take care of them at nighttime. If our program was eliminated, they have no choice but put them in the, nursing homes. And from my own experience, a lot of the nursing homes are not equipped to handle Alzheimer's and dementia population. Most likely, you know, that they would be sedated and forced to be bedridden. And I've seen a lot of these cases. How would you feel if you were sedated and forced to be bedridden, you know, for the rest of your life from that point onwards?
Thank you.
Good afternoon. I'm Dawn Myers-Perkey, and I've had the privilege of being the program director at YOLO Adult Day Health Center for the last 14 years. Our community-built program, and it's 26 years old. I'd like to respond to the bullets in your budget summary about the potential alternatives for adult day health. The first being IHSS. As you know, we serve the frailest of the frail. This is a very high acuity population. In-home support services does not have the medical or the social or the therapeutic services in order to even begin to meet the critical medical needs. Our folks generally have 10 plus chronic medical diagnoses. In terms of home health, I challenge you to find a medical home health agency that serves the Medi-Cal population unless by chance this person is just coming home from the hospital and will receive a very limited amount of service in the home. And that, as a matter of fact, is true for the Medicare population as well. And as far as clinics go, the problem with clinics is you have to be able to get there, and transportation is an enormous problem for this population, which is why transportation is a major part of our programs, and we have very specialized vehicles in order to do that. I'd like to reference. Oh, well, then I'd like to mention the 1115 waiver is coming right down the pike. And states like Minnesota and Wisconsin have realized now that it makes a lot of sense to work with adult day health for their high acuity populations. These are private managed care populations or insurance policies, and they recognize the contribution that